and Dr. Mohit Agarwal to present a memento to Dr. Dwarka Nath. Thank you. So now I request Dr. Dwarka Nath to address the gathering.
Thank you and welcome to Jodhpur. And first, let me begin by thanking the organizers led by Professor Deepak Jha, Professor Bhaskar, and Dr. Mohit Agarwal for the wonderful arrangements. And please, can we have a big hand for them? It's wonderful to see a lot of dignitaries on the dais, but nothing pleases me more than to see my teacher, Professor B.S. Sharma, on the dais as the chief guest. And Sir has not only been my teacher, he has also been my thesis guide both during my MS General Surgery days at PJ Chandigarh and also my MCS Neurosurgery at Aiims Delhi. Thank you, sir, for all what you have done and for all the wonderful lessons you have taught us. It's a pleasure to see you, sir. I also welcome Dr. Kuldeep Singh and Dr. Aditya Gwan, my members of the Executive Committee of the ISSFN. It's wonderful working with them. As you all know, ISSFN founded in 1994. It's a small but a very dedicated organization. And all the members here are very dedicated towards advancing the cause of functional neurosurgery. And even though we have around 175 members. And why I'm stressing this is because it's very important for functional neurosurgeons to take this field further along, because both functional neurosurgery and radiosurgery is going to be one of the pillars of neurosurgery in the future. There are more and more subjects which are coming under the ambit of functional neurosurgery, including pain management, spasticity management, neuromodulation, psychiatric disorders, etc. And over the next few decades, it's only expected that the functional neurosurgery will grow further and further. And with further increase in technology like HIFU, etc., it's going to become more accessible and more patients are going to demand functional neurosurgical procedures. So it's very important that functional neurosurgery is included more actively and taught more actively in more and more centers across the country. We've also noticed with pleasure that the functional neurosurgery is gradually spreading to all parts of the country, and more centers, including the Aiims in various parts of the country, are promoting functional neurosurgery aggressively. I was in Aiims Patna and we had a huge CME on movement disorders at Aiims Patna, and it is only important that all the neurosurgeons, the neurosurgery residents are exposed to both functional neurosurgery and radiosurgery in their MCH training, so they can take up this in the future in the big way. So I would like to end here and thank the organizing committee here again, and look forward to the next meeting at New Delhi, the conference of the Indian Society of Stereotactic and Functional Neurosurgery in 2024, which will be hosted by Professor Aditya Gupta in 2024. Thank you.
Thank you, Dwarka Nath. I request Dr. Aditya Gupta to address the gathering.
So I would like to greet all the dignitaries on the dais and of course the wonderful audience which has been there through all of the day today. I think personally it's a huge pleasure for me to be here at Aiims Jodhpur, and I would like to say whatever I have and wherever I have reached is largely due to my alma mater, which is Aiims New Delhi, and I carry the same feeling for all Aiims institutions wherever they are located in India. And it's also a special pleasure to have Dr. B.S. Sharma here, who has been one of the people who I would say has been my mentors, and also almost like a friend and an elder brother. And in fact, when he joined after that shortly, we were neighbors as well for a short period of time. So I have a very special bond with him. I think I am very impressed, first of all, by the Aiims Jodhpur campus. It is wonderful, spacious. All the buildings seem to be very well designed. It seems to be future ready for the next 20, 30 years at least. At Aiims New Delhi, where I did my MBBS, I joined in '89 and I left in 2009 after almost 8.5 years as faculty. So I saw the campus being encroached by buildings on all the sides and different centers coming up. So I think that is a natural progression, hopefully will happen to Aiims Jodhpur as well. But for the moment, I think it is a huge pleasure to see a beautiful campus, very, very well constructed, organized buildings. And even while I was doing the live surgical case today, I think the operating rooms, the equipment, the neurosurgery faculty, residents, nurses, technicians, was all actually exactly up to what I would expect from an Aiims. So a huge round of applause to the Department of Neurosurgery here in Aiims Jodhpur, both for doing the excellent work and also for hosting us for this very, very well organized conference. Thank you.
Thank you, Dr. Aditya Gupta, for those encouraging words. And I do understand that coming from someone who is based in Gurugram, Jodhpur is definitely heaven. You can see sky, that too blue sky throughout the day, sometimes even almost into the night. Thank you. I now request Professor B.S. Sharma, our chief guest for this function, to address the gathering.
Professor Kuldeep Singh, Dr. Deepak Jha, Milind Sankhe, Dr. Aditya Gupta, Dr. Dwarkanath, Mohit, Dr. Naveen Sharma, Dr. Sunil Garg, senior faculty, delegates, colleagues and friends, ladies and gentlemen. I'm honored to be here this evening, and I wish to thank Dr. Deepak Jha and his team for inviting me and giving an opportunity to interact with this group of 8 neuroscientists. I think he invited me because maybe that I am involved in the development of Aiims Jodhpur since its inception, and especially the Department of Neurosurgery. And I very proudly say that this department is known, already established as Department of Repute, Neurosurgery, in just less than 7 years. It's very well done, and it's very well developed department now. And what he is doing is that now he is concentrating on the subspecialties in neurosurgery, and this endoscopic surgery, neurointervention, and this now functional neurosurgery is developing in this department. So this is why this conference and this workshop were organized, and I am sure that after 5 years he will again organize such a conference of stereotactic and functional neurosurgery and show his cases, that how many cases they have done, and they will participate and show the cases lively performing in these workshops. Now, I have been associated with this department for 7 years and have tried to provide whatever help need, and again promise whatever I can do for this department, I am always ready. Now, just as a senior person, I would like to give some advice to all of my colleagues and juniors, that just follow some hobby, or give at least 1 hour to yourself. You may like to play, you may like to sing, you may like music or gymnastic or whatever, because this refreshes you and rejuvenates you, and once you are refreshed, you do your professional work with more vigor and with more sincerity, and this is how you excel in your professional responsibility also. Please look after your family well, because family depends on you only, and whenever you are working in any department, please work as a teamwork, because neurosurgery is nothing but a good team effort, good teamwork. Where there is a good team, that department always shines. With this, I wish all the success to this conference, and I hope that this society is a very close-knit society, and it will help all the departments who are trying to develop functional neurosurgery in their centers, and wish you all the best. Thank you very much.
Thank you, sir, for those kind words, and I'm sure all of us will take heed to your advice, especially the last part of developing hobbies and taking care of the families, which invariably does better in our professional life also. Thank you all. Now I all request you to stand up for the national anthem.
जय हे भारत भाग्य विधाता, पंजाब सिंध गुजरात मराठा द्राविड उत्कल बंगा, विंध्य हिमाचल यमुना गंगा उच्चल जलधि तरंगा, तव शुभ नामे जागे, तव शुभ आशीष मांगे, गाहे तव जय गाथा, जन गण मंगलदायक जय हे भारत भाग्य विधाता, जय हे जय हे जय हे जय 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 हे।
Thank you all for coming to the inauguration. I request you all to join us for high tea, and we will resume by 5 the remaining of the academic session. Thank you.
Good evening, everyone. Now let's move on to our next session, that is surgical management of pain and spasticity, utility of neuronavigation. I would like to call upon our esteemed
Excuse
chairperson.
me, I think Dr. Manmohan Singh's talk is still there from the last session.
Yes, ma'am.
So we'll have it after.
Ma'am, I just thought I'll invite the chairpersons and then we can carry on with this. The chairpersons, Dr. George, Dr. Manjul Tripathi, and Dr. Charulata.
Yeah, so can I invite Dr. Manmohan Singh to give his next talk on complications avoidance in DBS?
Okay. Good evening, everyone. So I'll be speaking on the complication avoidance. A lot of things have been already discussed for DBS surgery. So I'll be just enumerating the few important highlights for the youngsters. So during the DBS surgery, where you can go wrong. So it may be in the form of patient selection, then maybe frame fixation, image acquisition, both CT and MRI, fusion of the images, especially CT and MRI, trajectory planning, microelectrode recording, lead placement, and the tunneling of extension wires, and the IPG placement. So one can go wrong in any of these steps, and the whole of the procedure goes for actually 6. So in patient selection, Dr. Rupa Rajan has already discussed a lot of things. So this is the first step in achieving a successful surgery. The core assessment program for the surgical intervention therapies in the Parkinson's disease, guidelines for the patient selection. The presence of 2 or more of the cardinal features of the PD, exclusion of patients with atypical Parkinsonisms, disease duration of at least 5 years, 30% improvement in the UPDRS-3 motor score on dopaminergic agents. Deviating from these criteria doesn't mean that the DBS is likely to be a failure, but will lead to the less satisfying results and the higher rate of the complications. In the frame fixation, the frame is the paramount in any of the functions procedures, and you have to be correct in applying the frame. The frame base should be kept aligned along the orbitomeatal line, parallel to the, which is actually parallel to the ACPC line, then using the ear plug while fixing the frame, so that the pitch and yaw. So this is the pitch and the yaw. This is practically totally eliminated when we put the ear plugs. Ensure that the target is in the center of the stereotactic volume space. screws should be tightened gently, diagonally, only with the two fingers, that is the thumb and the index finger, so that you are not over tightening the screw so that it can plunge inside the cranial cavity. So in the traditional teaching is that you should tighten the screw only with the non-dominant hand. Ensure that there is no loose faith and once your frame is properly fixed. Stereotactic CT head acquisition, align the laser marking. This is also very important. So in every CT coordinate box, there are laser pointer lines. So that the CT lines should be absolutely parallel, aligned along those markers onto the CT coordinate plane, both in the Z plane, in the X plane, and as well as in the Y plane. So it is important. So make sure that these lines are parallel. You just can't put the patient in the CT gantry and take a CT scan. So the image evaluation. So make sure that once the images are acquired, we should verify that they are correctly placed. If there is any tilt in acquisition of the images, so this is actually here we calculate the Z. If this is of one dimension, this is of the other dimension, it means your frame is tilted and acquisition has been acquired in a wrong plane. So you have to go again and do so that these 2 points on each side, they are absolutely equal. And it is important. Otherwise, your Z is likely to be different. So once your imaging are fused, the stereotactic CT images are fused with the non-stereotactic MRI in a split screen fashion. So ensure that each sulcal, vessel, gyre are overlapping perfectly from top to bottom. So this is also very important. Pay attention to all vessels, gyri, sulci, and any other which is so that maybe a landmark in the form of the pineal calcification or some abnormality in the brain. So that make sure that everything is matching each other. Failure to achieve a good fusion, it may be due to the improper frame fixation or a frame is loose. There is the improper laser light alignment while acquiring the CT images. There is a CT gantry tilt. It has to be absolutely zero, and that is very important. And deviating from the protocols, it means that your final result is likely to be suboptimal. So these factors can significantly affect the accuracy of planning and the surgical outcome. Trajectory planning is important, and the trajectory should be planned in such a way that your trajectory is extraventricular, completely intraparenchymal without passing through any sulcal space and avoiding any vascular structures. This is important. Preventing infection, I think this is the surgeon's nightmare. So you have to go extra length to prevent infection at any cost. Absolute sterility is the key to the successful procedure. Implant infection is devastating. So meticulous painting, draping of the operative field, and make sure that there is a minimal crowd. And it has to be the first case in the morning, and the OT has to be absolutely fumigated a night before. The perioperative IV antibiotic cover and carried on post-operatively for 5 days. Generous use of antibiotic saline irrigation in the operative field through the procedure is mandatory. Checkpoints. The frame coordinates must be checked by 3 team members independently. I can tell you that here many times the things can go wrong, and you feel that you have fixed the frame properly, you have put the coordinate in the right way, but I can tell you that things can go wrong. So that the independent 3 observer in the OT, they must check that your X, Y, and Z coordinate has been properly put. So C-arm ring has to be aligned so that they are concentric with each. This is also important, so that it is not going to improve the outcome of the surgery, but at least if you can make sure on table that your leads are not deviated. If these rings are concentric, ideally there is also a crosshair also. This crosshair means that the center of the the 2 crosshairs are overlapping each other. So that is the center of your target. That is indirectly tells you that. So that it makes sure that 2 concentric rings are aligned with each other, and the center point is marked. And if your target is not at the center, it means that probably you are not in the right place. So this is unlikely to happen in the usual condition, but this is a secondary check. So entry point, the proper placement of the burr hole with no angulation, absolutely 90 degree to the skull. The burr hole rings must be fit snugly and should not be loose at any cost. That the burr hole ring, if it is loose, then it is likely to dislodge these electrodes, and your whole of the procedure may be gone wrong. The MER array tubes should not touch the dura ring inner table of the thumb. If your array tubes are touching the dura, so likelihood that it can get deviated. So make sure they are just touching the brain, going through the brain without any touching any of these structures. Only then it will go straight into the target. Preventing the brain shift, this is important. You have to make every effort so that the brain is not shifted. A very small neurotomy to be done to avoid CSF leak, only so that your tubes are going through it, and immediately you seal it with that fibrin sealant. So final lead placement checked during the CM. So this is the absolutely center, you touch there, and then you make sure that they are going to the target. So DBS lead fixation, the burr hole cap should be snugly fit into the ring after the DBS lead placement and ensure the firm fixation. Any loose fixation will promote the lead migration. Tunneling, I tell you that this looks a very small thing, but it also can change the outcome of your surgery. So make sure that tunneling for the connecting the wires should be deep subcutaneous. If they are into the superficial in the skin level or in the just under the dermis, they are likely to erode through the dermis and lead to the infections. The tunnel, free tunnel has to be there so that once, because these leads as well as the connecting wires, they are quite thick and with the very delicate wires inside them. So that if you are just stretching them, pulling them, you can break the wire inside so that the whole lead is left non-functional. So the wide free tunnel should be there without any tension, without any kink and twist. A separate skin incision at the mustard region behind the ear, which is my practice, and I feel that if you make another lesion, so you can pass these leads very freely without any tension. So that is important. So attaching the leads to the contacts, the care should be taken to identify the side and alignment of the contact point before the tightening the 4 screws. So these are the 4 lead contacts and this is the connecting wire. So that these metallic contacts should match to these things. So these they have, so that only then you can tighten the screws. So make sure that they are corresponding to each of these metallic contact point on the connecting wire, only then you tighten it up. So only torque hex wrench should be used for the tightening so that you are not over tightening, and if you are over tightening with a non-torque hex wrench, you can actually damage the lead also. IPG connection right cable is inserted into the inferior connecting port of the IPG, especially for the Medtronic, and the left cable is inserted. This is actually a international standard, so you don't deviate from that. So the DBS leads and the IPG placement, there should be a very few stain-free loop into the pouch, subcutaneous pouch, and so that it allows the free chest movements or head and neck. The lead under stain will promote the disconnection of or the lead migration or sometimes the breakage. They securely fix the IPG with the line and suture to the underlying tissue, so that many times this whole of the IPG get twisted and maybe flipped upside down, so that sometimes it's very difficult to wirelessly connect to your programmer also. So again, you have to ask the patient, once the patient is gone off, not to fiddle with that your IPG in the subcutaneous. Many people have the habit of just fiddling around with their IPG. They keep on doing something and they keep on rotating inside. So they have to be specifically told for that. And another thing is that again, full thickness skin flap over the IPG should be there. Otherwise, it is likely to erode through the skin. Post-op CT under the DBS protocol is done, and it is fused with the pre-op MRI to confirm that the proper position of the DBS lead and it has followed the trajectory. The whole procedure should be performed. I tell you, this is also very important, and I think even for the senior most neurosurgeon, this is the most important point. The whole procedure should be done by the chief surgeon from the frame fixation till the last suture, and he has to be present in the OT from the beginning to last. And because one wrong step, even you asked your assistant to pass a suture, to the, put a subcutaneous suture, maybe a cell suture. So even if a lead is caught into that suture, or even the needle hits the wire or connecting wires, so the whole procedure may have to be repeated because it's likely to be damaged. This is important. Thanks. Any questions? Welcome.
Any questions? No. We can move on to the next session.
Okay, thank you.
Thank you very much, Professor Manmohan, for telling us those important checkpoints to make DBS safe. We are, on behalf of Dr. Manjul and me, may I invite you to the next less glamorous aspect but rapidly evolving subspecialty of functional neurosurgery, management of pain, spasticity, and the utility of neuronavigation. I am honored to invite our first speaker, Dr. Rahul Lath, who is a consultant in neurosurgery from Apollo Hospital, Hyderabad, who would be speaking to us about percutaneous procedures for trigeminal neuralgia, technique and outcomes.
Respected chairpersons, seniors, friends and colleagues, I'll be speaking today on the percutaneous procedures for trigeminal neuralgia, the basic technique and outcomes. So trigeminal neuralgia, as we all know, is a very painful condition, and its incidence is not so uncommon. These are the clinical features: sharp pain in one or more divisions of the trigeminal nerve, trigger zones. It responds typically to pharmacological agents, especially carbamazepine, and on clinical examination, there are no deficits generally. And this is the normal pain distribution. The commonest is the V2, V3, and V1 alone is the most rare. Etiology of the classical trigeminal neuralgia is the idiopathic, or also called T1, is neurovascular conflict, the root entry zone, the trigeminal nerve from an artery, vein, or sometimes combination of both. Symptomatic trigeminal neuralgia is caused by some lesion like a tumor, epidermoid, schwannoma, demyelination, AVMs, etc. Atypical features: you have a deficit or motor deficit, bilateral TN, other cranial nerve deficits, younger age, doesn't respond to medical therapy, look for other causes. Imaging is usually done to rule out secondary causes and to look for special sequences, look for vascular compression. Management of trigeminal neuralgia initially is medical, and once the drugs fail, we think about surgical options. So what is refractory trigeminal neuralgia? So refractory TN, most patients respond to, 70% respond to medical therapy. The remaining 30% either respond initially and subsequently do not respond, or require higher doses of drugs or multiple drugs. So the general rule is, if you require more than one drug to control pain, a patient may be considered to have a TN. Should be at that time referred for a surgical procedure. Delayed surgery has usually bad outcomes. So what this is, I do all the three procedures. This is what I generally follow in my practice. The patient is fit for general anesthesia, a young patient. I usually encourage them to have a microvascular compression because that has the best results. We reserve the percutaneous procedures for patients who are elderly, who are not fit for anesthesia, or who for some reason want to avoid surgery. And I reserve the stereotactic radiosurgery for patients who are unfit even for sedation. So my numbers in this section are very poor. And just to know that any of these procedures can be used interchangeably. And if one fails, the other can be done. And if everything fails, finally you can even do a partial rhizotomy and cut the trigeminal nerve, the posterolateral. So today's topic is percutaneous procedures. There are three types. One is the radiofrequency ablation, which I do, and I will describe that, which is a heat. And we target the retrogastirian area, and you use heat to create a lesion. Visceral injections is a chemical method of producing a lesion. Last one is balloon compression, where you inflate a Bugatti kind of a balloon to create mechanical injury to the neural structures, large pain fiber. So radiofrequency ablation, the workup is done to do a pre-op workup, and especially BP control is very important because BP rises during these procedures. stop all antiplatelet coagulation. And you have to explain this procedure to the patient because you need the cooperation of the patient during the first part of the procedure. Very important. Usually it's done as a daycare admission, and you have to have the anesthetist on standby because sometimes they do get bradycardia. And the steps, these are the three main steps for a radiofrequency ablation. In fact, cannulation of the foramen ovale and the trigeminal cistern is the first step for all the three procedures. Thereafter, once we have entered the foramen ovale, we do a stimulation, produce a similar kind of pain which the patient gets. Once we know that we are in the correct place and stimulating the correct division required, then we then go ahead and produce a lesion. So this is the first step. So let's talk a bit about the anatomy of the foramen ovale. It is a elliptical foramen at the skull base. The orientation is anteromedial to posterolateral, and these are its major diameters. And you can see it is related to a lot of foramina there. Most important is the inferior orbital fissure, foramen lacerum, carotid canal, jugular foramen, and the eustachian tube goes from here into the pharynx. So these are the important structures to remember when we are doing this procedure. This is just to show you more detail on how your needle would go through, what structures, what is the angulation. There are two angles we see here. This angle on the lateral plane. And what are the normal structures parting to the foramen ovale? Mandibular nerve, lesser superficial petrosal nerve, accessory meningeal artery, and a lot of emissary veins from the cavernous sinus to the pterygoid plexus. So this technique to puncture the foramen ovale is more than 100 years old, and we're still in practice today. It is called the Hartel technique. Take a point 2.5 centimeters lateral to the angle of the mouth. This is the mid-pupillary line, 1 centimeter below the supraorbital fissure, orbit. And this is a point 2 to 3 centimeters anterior to the tragus. So the point where this plane and this plane meet, that is the point where you try and enter the foramen ovale, the Hartel technique. You see this goes through a lot of structures. The Stenson's duct, a lot of muscles, a lot of neurovascular structures, even though they are small. There are a lot of arteries and veins which you have to traverse normally to enter the foramen ovale. So once you puncture, these are the three divisions which you third, second, and first. And there are needles which can be manipulated for stimulation, which is called the tube needle. And the OT setup is very simple. You need an RF lesioning machine, you need an image intensifier, and you need an electrode and this needle. And this is the other machine which we have now, which we are using, the Heliard. And this is the other commonly used lesion generator. So once you need to do this in the theater. The first part is done in the local anesthesia and sedation. You puncture, and then once you puncture, you will see that there is CSF coming. In most of the cases, CSF comes out, and the patient is awake. And then you advance the needle to your desired area. You do both AP and lateral in the beginning stages to make sure you're in the foramen ovale. Nowadays, intra-op navigation is being used. There are some reports of robotic puncture of the foramen ovale also described. This is the robotic puncture. Next step is stimulation. You start at low voltage and you try to create the similar pain in the desired segment 1, 2, or 3. And depending on what current you have used, you can decide on the temperature of the lesion. If you are using high voltage to get you have to use higher temperature. Usually we do that in the recurrent cases. But for the first time cases, usually 60 degree or 60 seconds is the one. This is the stimulation being done. Yeah, this is the stimulation mode, the lesioning mode. And after that, okay, so what can go wrong? A lot of things can go wrong. If your needle goes to the orbit, you can have blindness. Goes into the foramen lacerum, you can injure the carotid artery. Laterally also carotid or the jugular. You can injure the eustachian tube. Okay? And incorrect nasal placement within the brain can cause a CCF, third, fourth, sixth, brainstem lesioning if you are very deep. And sometimes, very rarely, you can have brain abscess or meningitis. Just showing you the needle, the foramen ovale. You can enter the cavernous sinus, nerves, arteries. A lot of injuries can happen. Anyway, even if your needle is going correctly, you can still have damage to the Stenson struct, can puncture the arteries and veins and produce a facial hematoma. And with the correct needle placement within the intracranial compartment also, you can have injuries to the tensor tympani, you can have B1 damage and corneal ulceration, masseter weakness, and pericardial hypotension and CSF fistula. This is the complications, one of the largest series, various complications mostly related to the fifth nerve. Most of them are doing that. What important thing here is almost no mortality. Long-term recurrence are about 25 to 30%. This is the long-term graph showing that over a long-term period you have 50% recurrence rates in this procedure. When you compare that to Geneta series, is 80% long-term survival. This is the RF lesioning. And this is stereotactic radiosurgery, not the Marcel, but the Konziolka and Lunsford, their series, long-term follow. So this is my personal series of 161 patients. So most patients had immediate relief. One patient that we couldn't do was abandoned. And most patients had lesions for 60 seconds each. And 2 lesions were made for most patients. These are the complications which I had. And those with recurrence were treated with the RF, repeat RF, MVD or medical therapy. Next procedure is balloon compression. Just to show you, the first part is the same. Secondly, a balloon is inflated for a short time to create mechanically. This is the balloon. This is one of the largest series showing that 88% long-term good control. Visceral osteotomy again.
Sir, kindly conclude, sir. Actually,
Yeah,
we're
conclude.
already.
Okay. So, this is just to show you that radiofrequency, amongst all the percutaneous procedures, radiofrequency has the least recurrence rate. Most complications happen with the percutaneous balloon compression. So, the take-home message here is that percutaneous procedures are to be considered for patients with refractory neuralgia, not suitable for MVD or recurrence after MVD and other procedures. It's a relatively safe procedure and cost-effective also. Causes immediate pain relief in most of the patients. And amongst the percutaneous procedures, radiofrequency has the highest rate of pain relief with low recurrence rates. This is the final chart. Thank you.
Thank you, sir. The house is open for this. Okay. A quick question, one quick question.
Thank you very much, Dr. Rahul, for that fascinating talk. I would like to ask a question on behalf of some of the young faculty I see here. So, young faculty from Aiims Raebareli and Aiims Jodhpur would like to get this procedure started as a new initiative in their department. How would you practically advise them to go about it, and how many cases probably to reach a level of basic expertise?
Okay, first thing is you need to get a skull bone or a cadaver, practice the puncture there, and try and see the X-rays. Okay, and how do you want to start it? You need to obtain if you're doing a RF, there are machines which are available, Indian machines also, but I showed you the 3 companies. Avionics is no longer being made, either Heliard or the Cosmans. You obtain that lesion generator and the electrodes which the company will provide. And I think you have just to start with the practice, start lesioning.
Thank you so much, sir. Now I invite Dr. Milind Sankhe, consultant neurosurgeon in the Aiims Jodhpur Hospital. He will be speaking on the time-tested and the gold standard treatment modality for trigeminal neuralgia, the microvascular decompression, operative technique and the outcomes.
So till he sets up the computer, we do it here also using glycerol, and we prefer to go for surgical. We give surgical options first, and if it fails, if there are other indications like multiple sclerosis, then we go for it.
Perfect. Good evening. So I'm start off. Thank you for the wonderful organization. Congratulations to Deepak, Bhaskar, and Mohit, and the rest of the team for a wonderful organization. And thank you for the hospitality. I'm going to talk briefly on microvascular decompression, also known as the Geneta procedure. And before Geneta actually described neurovascular decompression, there was a description by Sir Victor Horsley in 1891 and later Walter Dandy. The indications, as we all know about microvascular decompression, common indications are trigeminal neuralgia, hemifacial spasm, tinnitus, vertigo, has been described for neurogenic hypertension as well. And a lot of work has gone into that, but these are the few common indications which we'll just talk about. Briefly, a couple of slides about the procedure and then the literature review. Procedure done in either in a lateral position as shown in the picture. I personally do it in a supine position with the head elevated by about 30 degrees, turn to the other side by about 45 to 60 degrees with shoulder support, making sure that there is no airway or any venous compromise, and lateral flexion depending upon the indication that we have. For someone with trigeminal neuralgia, you do not need much of lateral flexion. Incision, something which we are all very familiar with. You first mark out what your surface marking for your transverse sinus and the sigmoid sinus is going to be, and try and make sure that your incision for trigeminal neuralgia is half above, half below. Whereas if you're doing something like a hemifacial spasm, then it is slightly lower, and if you're doing something for tinnitus, again the same. The use of para and facial nerve monitoring, I would like to emphasize that it should be a mandatory practice. It is something which we are doing almost every time, and it's soon, not using it is probably going to be in future a punishable thing as well. So this is a very standard thing. What I would like to just emphasize upon is the retraction is not in the direction away from lateral to medial, but it should be from supero-inferior, and as seen here, it's just doing some arachnoidal dissection, identifying the loop, pulling the loop out. Once you've done mobilizing the loop, essentially placing a graft around, making sure that the grafts are placed. Once you've essentially got the loops mobilized and placed the Teflon, you hold the Teflon in place using PCL glue. So some of the important steps, just for revision: good positioning, craniotomy placement and exposure of the angle between the transverse sinus and the sigmoid sinus, appropriate CSF drainage, cerebellar retraction at the angle directed inferiorly for trigeminal neuralgia, avoid injury to the petrosal vein, arachnoidal dissection to identify the nerve and the offending vessels along the nerve, along the entire segment. You want to do a transposition or an interposition, preferably making sure that you hold the place, but it's much easier to just use the glue as such, and adequate steps for preventing CSF leak. Coming to the topic which has been given, which is complications and outcomes of MVD. So the three most important complications are cerebellar injury, hearing loss, and the CSF leak. Hemorrhage, as we all grow, hemorrhage is something which you rarely see. It's just making sure that you do the craniotomy placement appropriately. Cerebellar injury is just something which you need to be really careful about, just letting sure that you don't really cause any significant retraction. And hearing loss is probably the most important, and which we'll emphasize upon. So this was a paper which was by the Peter Janetta group. He actually compared his personal work in pre-1990 and post-1990, and okay, it is nicely visible out there. You would realize that the hearing loss incidence has actually reduced with the advent of better microscopes and better understanding of the whole thing. And clearly, the hearing loss is the most important thing. Cerebellar injury as such goes down in the future. CSF leak is something which eventually all of us realize that this can be taken care of. So, and I'm again emphasizing on the hearing loss as such. So he also went on, I also reviewed prognostic factors about the outcomes following in MVD. So this was a paper which was by the Mark Sindhu group, where severity of the compression was the most important factor. The more severe the compression, better the outcome. There was no role for age, sex, duration or hypertension as such. They had no role. Some of the debatable points which are raised in this paper are previous surgery, the type of pain and type of compressive vessel. He essentially says that these don't matter. I'm not so sure whether previous surgery as such and type of pain, whether typical, atypical, he goes on to claim the same results. Something which he says very clearly is negative factors that if there is focal arachnoiditis, then you're likely to get a poor result. in the similar, in another paper which Mark Sindhu writes, he talks about the role of degree of conflict of compression, which is essentially the same, that the severity of the compression really matters. And he classifies the severity into grade 1, grade 2 and grade 3. More severe the compression, better the outcome from pain relief. He actually goes on to check the compression and predict the outcome on the, depending on the grades which can be seen on the MRI scan. Seeing the MRI scan, and then he correlated, making it a blinded study, that there was, in particularly if it was a grade 1 compression, then there was a significant overestimation in terms of pain relief by the blinded, by the assessment. And whereas grade 2, it was almost equivalent, about 73%, whereas the best results, which was about 85%, in which they had severe compressions, that is grade 3 compressions. Coming to the typical and atypical, he goes on to claim similar results, but I am not so sure about this, because we all have experience about it, and there are multiple other papers which do not actually describe the same. Coming to microvascular decompression for hemifacial spasms. So, I personally do not have a large experience with hemifacial spasms. As such, I would not be able to claim more than about 7 cases for microvascular decompressions for hemifacial spasm. This was a paper which was actually again by the Peter Janetta group, where they found the offending vessel to be, most common offending vessel to be the pica, which is obvious for everyone, and the second most common vessel to be Ica. Assessing his similar, the same paper, he has, these are about 703 patients on, with 705 sites in it. That means 2 patients had done on both the sides over a period of 1 to 20 years follow-up. The mean follow-up was about 8 years. Almost, he claims 84% of excellent results and about 7% partial results 10 years post-operatively, and these were all de novo operations. Patients with typical onset of symptoms, that means starting at the inferior orbit, that means the typical hemifacial spasm, he claims that these results and have better results. Whereas, and the complications for hemifacial spasm included predominantly again hearing loss. Coming to something similar, fantastic meta-analysis from the Aiims Delhi group, quite a few of them are sitting here, and very clearly it says over here, I don't know whether it projects there nicely, temporary facial paresis and permanent hearing loss, and temporary hearing loss was the most important things which mattered. This was a meta-analysis of a significant number of papers which included 27 papers. Again, in the same group, clearly it showed that the long-term success results with hemifacial spasm surgery are very, very good. Coming to MVD for tinnitus and vertigo, over here, independently for tinnitus and independently for vertigo, the results have not been as good, ranging to about average of 22% to 27%, but a combination of tinnitus and vertigo undergoing microvascular decompression. This analysis was done using 35 studies with 572 patients. A combination of tinnitus and vertigo showed benefit in the range of about 62%. However, what was the drawback? Almost 5% of them had significant hearing loss, and all this hearing loss was permanent hearing loss. So, what does it tell us? That hearing loss is the most important factor which or complication which one needs to be aware about in microvascular decompression, and the best way to prevent is to make sure that we use intraoperative BERA. Some of the difficult situations for microvascular decompression are dolichoectatic vertebrobasilar artery, previous surgeries or additional pathologies. This was another paper which actually reviewed the same. Over here, the only thing that conclusively tells us, this paper tells us, is that the Teflon implant should not move around 2 minutes. Teflon implant should not move around, and there should be enough attention paid to make sure that the Teflon doesn't move, particularly dolichoectatic basilar. Some of the additional pathologies and personal experiences. This is one patient who has trigeminal neuralgia, he has hemifacial spasm, and he has a large pituitary adenoma as well. Another such patient who had Right-sided trigeminal neuralgia and right-sided A1 fusiform aneurysm had to undergo the clipping of aneurysm first, followed by microvascular decompression. This is the same patient's CT angiogram, pre-surgery, and the post-surgery was shown earlier. This is the intraoperative picture of the same patient. Intraoperative video, the same patient, clearly showing vertebrobasilar dolichoectatic and this. One of the things that happens with this is that you have compression from both the sides, not just from one side. And this is the use of Gore-Tex graft, because I like the Gore-Tex graft as such because it stays in place much more easily. And you need to make sure that your nerve is covered completely. To conclude, it's a very, very safe and effective procedure. I don't think there's any doubt about its efficacy. Trigeminal neuralgia and hemifacial spasm respond very well. I wouldn't say the same for tinnitus and vertigo. Hearing loss is the most important. Intraoperative monitoring should be a mandatory practice. Thank you for your attention.
Thank you so much, sir. It's a single question. Anybody? Dr. Aditya wants.
Thanks, Milind. I think you made some very, very important teaching points for the younger colleagues. I would only like to add one another caveat for the MVD good outcome. The recently for past 3-4 years, what I've been practicing is no retraction at all.
Absolutely.
So no cerebellar retraction, because then you don't get cerebellar contusion, you don't get SPV bleeding, you're not retracting the 7th-8th complex. I don't even incise the arachnoid over the 7th-8th complex. I just start incising it superiorly from that point.
Absolutely.
So these 2-3 things have really improved the outcomes of MVD.
Particularly for trigeminal neuralgia, you don't need to necessarily see the 7th, 8th at all. You just need to see it in one corner, which should be just at the faint end.
What's your policy when there is no documented radiological conflict?
Okay. So no documentary radiological conflict. Should you really go ahead or not? That was one of the papers which Mark Sindhu put it up, saying that whether he found it or not, he was trying to assess. So many of the patients whom I have operated upon, I would not do it. I just don't do it. Listen until. So then I discuss the options of alternative forms of treatment for them, which includes gamma knife as well as RF lesioning. I don't do it as such, but I don't really venture into doing vascular decompression myself. I'm sure argumentatively you can say that you expose it, do a bit of a rhizotomy, and that should be good enough. All that is fine, but I'm not getting into that at all.
Thank you very much, sir. Let's give a big round of applause to the President-elect of the ISSFN, Professor Milind Sankhe. Next, we delve into a relatively less explored subspecialty of functional neurosurgery, that is pain, which is so personal and unmeasurable. And to tell us about operative procedures of the spinal cord for intractable pain, rhizotomy and spinal cord stimulation, it's my privilege to invite Professor Deepak Agarwal from Aiims New Delhi.
Thank you again. So I'll be talking about, as mentioned, RES and some parts spinal cord stimulation. Pain is the most terrible lot of mankind, more than even death itself. And who knows it better than those patients who have brachial neuralgia or other kinds of pain syndromes with which they are living daily. Redifferentiation pain or neuropathic pain is caused by the interruption of the peripheral or central inputs to the central system. This causes brachial plexus. And why we have in India, this is the two-wheeler capital of the world. In fact, in India, the maximum number of two-wheelers were sold last year. So, in Aims Delhi itself, we get around 500 or so patients of brachial plexus every year, of which 70% will have a brachial neuralgia. However, most of these patients, the brachial neuralgia settles over time. So you are left with a small percentage which will have intractable pain throughout their lives under stress. Spinal cord stimulation has been tried in these patients with favorable results, but favorable means 50% efficacy. And so obviously a lot of these patients will still be left with no option. And spinal cord stimulation, as we all know, is relatively expensive, not available to all the patients. In comparison, micro DRES, which we have been doing at Aims for some time now, is very, very cheap, readily available. So I'll be quickly talking about the anatomy. And if you look at this slide, this is the posterior column. You can see the dorsal root coming out. And the dorsal root entry zone is just, I would say, lateral to the entry of the roots. To show it better, we have the posterior columns here. We have the lateral corticospinal on this lateral to it. And in between the two, we have the sulcus through which we enter to do the resortment. So Mark Sindhu was the one who in 1972, and it is a very, very old procedure. However, because of the complications associated with it, fell into disrepute. It was not done by a lot of neurosurgeons. What we do is, when we enter the cord or the gray matter, we enter up to the level layer 5. And the layer 5 is the one which subserves the pain, the fibers. And if you destroy these fibers, pain relief is immediate and long lasting. So usually we enter in the plane of the operative field, which is around 25 to 45 degrees angulation, in parallel to the sulcus. So you don't have to really measure the angulation or anything. You just enter the sulcus, and that is the natural angle you will enter it, and 3 millimeters inside. So previously what used to happen when this technique was introduced, that they were using radiofrequency ablation or other kinds of destructive methods, and even percutaneous methods were tried. So obviously in such a small area, if you do all this, there's a high chances of the temperature spreading and causing complications surrounding. In 2004, there was, we were introduced to this DRES technique when Professor Tiara from Japan came and did a workshop at Aims. And he actually used a bipolar cautery with a very fine taper. I think it was around 0.1 millimeter tip, specially fabricated. And he used to do the procedure using that bipolar forceps. As we did not have a forceps as thin as that with us, we, I said, improvised, and we started using the standard micro scissors. So what we did is, we are only using the micro scissors. We are not using the bipolar except for the superficial coagulation. And using the scissors, we open the pia mater and go into the sulcus. So this is a very short video. So you can, this is a case who had a complete brachial plexus injury. This is caudal, as you can see. And we do a hemilaminectomy. So we do not remove the whole lamina, only on one side we remove. Counterintuitively, the dorsal roots come out very close to the midline. So we do not need to go laterally. If you go laterally, that is one of the problems. You will enter into you'll have a lot of bleeding from the venous sinuses. So you have to, this incision is giving very close to the midline. So when you open up, you can actually see there are no nerves, because they have already been destroyed by the brachial plexus injury. Only the cranial most, you can see the C3 roots coming out. There is nothing, no roots anywhere right up to C7. But you can see a small sulcus here with neovascularization. and you have to enter the sulcus. So here we are entering into the sulcus. The beauty of this procedure is that once you enter into the sulcus, you can, I'll pause this video, so you can see these vertical vessels. These are the vessels under the pia on the, this is the lateral spinothalamic tract. So they are on these lateral spinothalamic tract, and this side is the posterior column. So you can see vertical vessels, which ensures that you have not breached the pia matter. And you can see them very nicely. You keep I would say, continuing with your incision and gradually widening it. Only thing we use the bipolar is for coagulation of the superficial vessels which are crossing, and the rest of the procedure is done only with the microscissors. And at the end of the procedure, it opens up, the whole cord opens up like a book. And here I marked the scissors at 2 millimeters, so I can actually see if my depth is what I have decided preoperatively. Then we close it as we normally do. So although it looks like a simple procedure, and it is actually a very, very simple procedure, it is associated with complications. And we published a paper initially in 2019. This is a patient. He was actually a police constable. I have shown this, I think, patient before also, many times. He had a brachial plexus injury 10 years prior to presentation to us, and due to a road traffic accident. And he had so much pain that he actually committed suicide by using his licensed revolver thrice, each time unsuccessfully. And so he landed up with us, and he was the first patient we operated on actually. And when he came out of the OT, the pain relief should be instantaneous. But when we asked him, he said there is no relief in my pain. So we were very disappointed and we didn't know what to do. 24 hours later, when we came back to him, he said, now I can feel the relief. It took me 24 hours for my brain to understand that the pain had disappeared. So for a person who's carrying this pain for decades, it takes some time for them to really get over the thought that this pain is no longer there. And we then published a series. Till 2009, we had done around 60 cases, and we had excellent to good relief in more than 85 to 90% of the patients. And there were some deficits, most of them transient, and that is because of retraction of the corticospinal tracts. This is the slide most important. You have a learning curve. Despite it being a simple procedure, there is a learning curve. And you can see that the complications will decrease with time as you learn the nuances. So in case it fails, for those patients, we can do a redo dress, and it has an equally beneficial role, because another 70% of these patients will improve with the second dress. And it looks like a virgin area. When you go, there is no scarring, nothing. It looks like an open book, as if you just closed the incision yesterday. So that's the beauty of a redo dress. So I'll just close that. You can use the same procedure for, I would say, spasticity also. You can do the same procedure in the lumbar region and at the conus level. So we do this procedure to decrease spasticity in head injured patients and severe spasticity for other causes. And you have remarkable relief in the spasticity. Same procedure, no difference, but the spasticity also disappears. Ashworth grade 1. It may be 4 before, but it becomes 1. And there are other indications, obviously. We can use it for pain due to phantom limb syndrome or other causes. And I would say it is one of the simplest cost-effective techniques we have in our armamentarium, which any neurosurgeon in any neurosurgical facility can do. Thank you so much.
Thank you so much, sir, for such a lucid description, and I think this is one of the most rewarding procedure both for the surgeon and the patient. It's a complete pain relief. And sir, what do you recommend when the patient has no relief? Like in 2 patients, you didn't have any relief, and we are already going for a destructive procedure in a very beginning. So what are the options left with us?
Options become limited. The option of spinal cord stimulation is always there. And beyond spinal cord stimulation, I gave a talk in the morning also, and that was on thalamic gamma knife. So we can do a VPN lesioning. So a lot of options are there, provided you are aware of the options. So all these, first we start from the least, I would say, invasive, which is spinal cord stimulation. If he cannot afford spinal cord stimulation, we might offer him gamma knife or stereotactic lesion.
So what about the morphine pump?
Sorry?
Morphine pump.
Morphine pump is an option, yes. But I have no, I don't think, it's very difficult to actually, I would say, procure and administer it. We had, even for baclofen, when we were trying it, suddenly we implanted baclofen pumps in few patients, and then baclofen became unavailable in India. So it became a huge problem for these patients. And similarly for, morphine and all these drugs where we require replenishment, it may be an issue at some point for our patients. So we haven't got any experience.
Any other question from the audience for Dr. Deepak?
Regarding the baclofen as such, one of the biggest problems is the availability, and to try and give baclofen and refill with a 500 microgram per ml, it just exhausts itself so quickly, and even that higher dose, whereas in Europe you're getting something like a 10,000 microgram per ml, whereas here you're getting 500 microgram per ml, and it's such a struggle getting it as well. Regarding morphine pump, again, getting the morphine, which is intrathecal morphine, which is available, but again, the refill and the filter process is again something which is a big challenge, and the pumps actually get blocked because of a poor filter quality as well.
Thank you so much, sir. And now I invite Dr. Jitin.
Okay, go ahead.
Yes,
so
please.
In between the things done, you please invite.
Yeah, I invite Dr. Jitin, who is in NSCB Medical College, Jabalpur, and leading the functional neurosurgery in Jabalpur. Good friend. And he will be speaking on another important topic, that patient selection and neurosurgical options for the relief of spasticity.
So Dr. Mang Garg has learned this technique from you. We get few patients, but whenever a patient comes, Dr. Mang does it. Results are rewarding so far. And Dr. Mang is also doing everything for this conference. Mang and Mohit, these two are the most busy people. Nobody is taking his name. So he is there. So he does this surgery very nicely.
No, I think they have done an excellent job.
Yeah, Mang does it nicely.
I learned from his video only, because I do the dress and just looked at the video of Dr. Deepak. So, Dr. Jitin, please.
Thank you, respected chairpersons, Professor Deepak sir, Mayank sir, Mohit, for giving the opportunity. So I'll be continuing with the Deepak sir's presentation. I'll be speaking on patient selection and neurosurgical options for spasticity. So spasticity is a frequent encounter for all of us, and it can be seen after trauma, brain, spine, stroke, cerebral palsy, multiple sclerosis, and often we need to treat the spasticity. And we should individualize the patient, and then offer them either a reversible or permanent procedure or a general or focal procedure. For a patient who wants a general and reversible procedure, intrathecal baclofen is a good option. For reversible and focal ones, Botox. For permanent and generalized spasticity, we can offer dress lesioning or dorsal rhizotomy. And for permanent focal ones, we can offer neurotomy. For evaluation of patient, we need to take appropriate history and perfectly examine him clinically. Important is to differentiate the spasticity from contractures, rigidity and dystonia, because all of these have different surgical options. We should record the patients on different scales of spasticity, as well as examine their spontaneous postures in motion and as well as in angles. Stress should be upon what is the problem for that patient. He may be having whole hemiplegic spasticity, but the problem may be in his ankle and toes or and wrist or fingers. Because hip and knee spasticity, that tone helps the patient in standing. So you need not to treat the whole of the limb, and only treat the thing which is problematic for that patient. For the diffuse spasticity in adults, as I said, intrathecal baclofen and dress lesioning is a good option. For focalized spasticity, hyperselective neurotomies. And for proximal predominant hemiplegic spasticity, we can go for dress lesioning. For distal predominance is neurotomy, and for focalized also for neurotomies. First, we need to understand the child's function and disability, and we need to act when the scoring decreases. and then we can add the surgical option, and then again the motor function starts improving. And for cerebral palsy, selective dorsal rhizotomy is a very good option. Botox helps to buy the time and stimulates the outcome, and so we can communicate with the patient that this is how your baby or patient will look after the surgery. Peripheral neurotomy, which is my favorite, involves 50 to 80% lesioning of the targeted nerves, and it can be either trunculotomy, that is opening the trunk of the peripheral nerve, or going up to the peripheral branches of the nerve to that muscle, which is known as selective neurotomy. And then we need to lyse 60 to 70% of the fibers and resect out 3 to 5 millimeters of the fibers to avoid recurrence. For lower limb, we can go for hip for obturator neurotomy, for knee for hamstring neurotomy, for foot and toes tibial neurotomy, and for extensor hallucis anterior neurotomy. And for upper limb, for shoulder muscles, we can go for pectoralis major and teres major, elbow musculocutaneous, and for wrist and fingers median ulnar. I'll be showing some of the examples. Like this was a patient of preoperatively. He was having equinovarus deformity in ankle and as well as claw toes, and in the postoperative period, you can see almost straightening of the foot. So you can also compare preoperative and postoperative movements, and if you look closely, there is reappearance of dorsiflexion of the toes, and which is because there is rebalancing of extensor and flexor muscles, and this is quite nicely possible with peripheral neurotomies. So this is a short video of that. This is left popliteal fossa of medial lateral, and then we need to incise this subcutaneous superficial and deep fascia, and we need to go between the two lateral heads of between two gastrocnemius heads. And this is tibial trunk, this is medial gastrocnemius and then lateral gastrocnemius, and then we need to dissect these nerves up to their peripheral branches, as I said. And this is sensory, this is nerve to soleus. Intraoperative neuromonitoring helps a lot in identifying these nerves, and this is posterior tibial. So you need to stimulate each of them, and you need to spare the sensory one, otherwise there will be painful neuromalformations. And as I said, neuromonitoring is very helpful in diagnosing which nerve is which. And then you open, and then you need to lyse these nerves in 3 to 5 millimeter length. Lastly, you need to open the trunk of the tibial nerve and expose each toe and other toes, and then do the similar procedure. I'll skip the images. Another preoperative and postoperative outcome. For elbow, as I said, you need to open like an oberling procedure, dissect out the biceps and brachialis, branches to bicep brachialis. For median nerve, we need to open at the cubital fossa, retract the plantar teres supro laterally and flexor digitorum superficialis medially, and here you will find the median nerve. For the ulnar nerve, you need to open at the cubital tunnel. You can also do this procedure for old spinal fractures, like in this patient, which she cannot stand. Every time she had a clonus, very painful clonus in fact, and after the procedure, she also had contractures in the achialis, so she underwent bilateral tibial neurotomy with bilateral achialis tendon tenotomy in the same setting, and the result was very good. Trizotomy has already been spoken by Deepak sir. Only thing is we need to go deeper, approximately 5 millimeter in depth for spasticity. And this is a very good procedure when spasticity is accompanied with pain. Selective dorsal rhizotomy is very good procedure for cerebral palsy. We need to do laminotomy or laminectomy, take out the individual dorsal roots, stimulate them, see which are the nerves which are abnormally stimulating the myotomes, open those roots, take out the rootlets, and then again stimulate them and lyse them. The results are excellent for all of the techniques. Even the long-term outcomes are there. Only thing is, after 5 years, the efficacy starts to dip. It comes around 50 to 60% of the original one. But still, it is very good. And these procedures are very cost-effective if you compare them with the baclofen pumps, etc. Comparing DRES lesioning with selective dorsal rhizotomy, there is one clinical trial which has said that DRES lesioning is very effective for reducing spasticity, but DRES is comparatively more destructive than SDR. But and breast lesioning should be preferred for bedridden and SDR for ambulatory patients. I mean, this can be debated. On comparing different options, most of that already been spoken. But importantly is in our country, the breast lesioning and peripheral neurotomies hold their place, and spasticity is such a common problem, and this low-cost solution should be taken care. To summarize, the aim of this surgery is to suppress the excess tone and achieve rebalancing of flexor and extensor group of muscles. Intraoperative neuromonitoring is vital. Peripheral neurotomies is an excellent option for relieving focal and hemiplegic spastic patients. DRES and SDR are options when the entire limb is affected. We need to differentiate the dynamic spasticity from fixed contractures, and most importantly, rehabilitation is critical. Thank you, sir.
Thank you very much, Dr. Jitin, for sharing your fascinating experience from that very relatively uncharted territory. We have time for one question from the floor of the house.
You use any nerve monitoring when you do this peripheral neurectomy?
Yes, sir.
We use stimulator throughout the procedure?
Yes, we use neuromonitoring, sir. All the cases.
Thank you very much, Dr. Jitin. And the last person who asked the question is the next speaker. It's my privilege to invite Dr. Raghuram, who will be speaking to us about the principles and applications of neuronavigation. Dr. Raghuram is a consultant at Manipal Hospital, Bangalore.
Thank you so much, George, for the kind introduction. I just moved to Fortis. So, the respected chairpersons, thank you, Professor Deepak. And Dr. Mohit for the kind invitation. Thank you, the office bearers of the Issfn, for giving me this opportunity. Dear friends, so it is, I think all of us have heard about a lot about stereotaxy from the morning. So I'm just going to delve into the same topic, a little more only concerning about frameless, which is neuronavigation. Sorry for the delay. Thank you. So, let's move, yeah. So first going to the definition of neuronavigation, this is a Oxford Dictionary navigation, the first one is, which is the process of or an activity of accurately asserting the one's position in space or wherever you're traveling and planning and following a specific route. So that's what navigation means. And as functional neurosurgeons or general neurosurgeons, now all of us want to make sure that we get an excellent outcome in whatever kind of surgery that we do. So we don't want a problem or a difficulty when we are approaching a particular lesion, and we want to make sure that we excise maximally and safely. So that is what neuronavigation does. So it is a set of computer-assisted technologies used by neurosurgeons which help in guiding or navigating within the confines of the skull or the vertebral column, because we also have spine navigation. So that's what it means in neuronavigation. These are a few learning objectives that I thought I will speak when I'm talking about the basics of neuronavigation. Both frame-based and frameless are there. Frame-based has been extensively spoken about by earlier speakers. So I'll be sticking to frameless. And I will also talk about the steps and the applications and the future of neuronavigation. So this already, Dr. Dwarka has already spoken. So starting with last Lexel is the kind of revolution that we saw in terms of stereotaxy. So these are the current commonly available 3 frames, the CRW frame, the Lexel G frame, and the Lexel Vantage frame. but I'm not going to talk in detail about that. Coming to the history of frameless, it was Dr. David Roberts from Dartmouth in US who first developed the first frameless stereotactic system. The advantage of this system was the ability to track a surgical instrument or a probe in real time and project it into the preoperative image or the preoperative MRI or CT. So I think that is the most important principle that we need to understand when we talk of neuronavigation. So brain is a geometrical volume, so it's not like uniplanar. We know it is composed of the volume structure, so it has an axial, sagittal and coronal plane. We use the Cartesian coordinate system when we do a frame-based stereotaxy. It's already been spoken about. What they have developed in neuronavigation is an interface which correlates this preoperative image that we have in terms of volume sequences into the intraoperative field, that is when we are operating. So that is the most important thing that we need to understand. We need a device which correlates the patient's head into the image data. Usually what we do normally is to, based on our anatomical knowledge and experience, we plan the trajectory, we plan the operation and the flap, whereas the neuronavigation machine integrates these two systems and helps us to do a better job. So basically we have three main components of neuronavigation. Most important is the preoperative imaging data, which could be either an MRI and CT, and there are very specific sequences that we can do, and all of them should also be what is called as a navigation compatible sequence. I think that is the most important thing. I'm not going too much in detail into the sequence because that itself is a separate talk. So navigation compatible sequencing is very important. We need to tell the MR or the CT tech to do the appropriate sequence. A localizing tool that we need is which will track the neuronavigation system and will also serve as a pointer during the surgery. So we have a tool which will show the neuronavigation machine where it is, where the position of the head is, and how it will correlate to the preoperative or the image data that is there on the system. And we have a mathematical framework which calculates this relationship between the patient's anatomy and the preoperative imaging. So we have various devices available. The most commonly used devices are these three: Medtronic, Stealth and BrainLab. The EasyNav2, just a few words, is one of the systems that is developed by an Indian company. We were part of this guy, his name is Arpit. When they started the research, we are happy to note that they are doing very well now and it's quite popular among many people all over India. So this is how it looks. So coming to the applications, obviously all of us, if there is a surfacing tumor which is very big, maybe we won't need navigation so much. But if there are small deep-seated intracranial lesions which are very deep and we need to use a safe approach to this particular tumor, and in terms of intracranial biopsies, we already saw in the morning about a frame-guided biopsy. I will show you about frameless biopsy and how safe it is right now to do that. Even in skull-based surgery, neuronavigation may be very useful, especially to look at the location of the structures, also to identify tumors which enter into the bony crevices. Even in intracranial endoscopy, it may help us to get orientation within the ventricles and to remove the tumors or to do even a third ventriculostomy. It is very, very useful neuronavigation. And the last one, the other important thing which very commonly used nowadays is the spinal navigation, especially for patients in correction of scoliosis and for posterior cervical and CV junction anomalies. What is the advantage of using neuronavigation? Obviously, you can do a more smaller and more precise craniotomies. We can improve the extent of excision, like what I was telling you in the beginning, without damaging the surrounding structures. I think that gives us the extra confidence that we are able to remove the full tumor, and also by using multiple sequences like tractography or spectroscopy, we can identify the area of the lesion, preserve the fibers, go around it without destroying them and remove the tumor completely, in turn improving the prognosis for the patient. In functional neurosurgery, it can be used for DBS, commonly used for stereoelectroencephalogram, and robotic assisted surgery, which itself my next speaker is going to speak. So what are the steps of neuronavigation? The most important step, like I already told you, is to have a good preoperative imaging. So if the patient comes from outside with an image in a diagnostic center, they may not be compatible with neuronavigation, so we need to check that, make sure that the imaging is navigation appropriate, and then load it onto this planning software. We'll have to position the patient in which the line of sight of the device and the tracker is appropriate so that no other instrument or this line of sight is not blocked. Next is important is the attachment of the tracker device. The tracker device, I will show you, can be attached either to the table or to the frame. And the next and the most important step in neuronavigation is what is called registration. I will speak a minute on that subsequently. And then once you register, then you are ready for navigation and use what is called as an intraoperative localization. And the last part is the navigation of during the whole procedure. So this I already told you, either you can have a CD or you can have a PACS integrated so that the images are pushed onto the navigation machine. And when you do this imaging, the other important point which we already discussed in the morning is to have fiducials. Fiducials is basically more for frame fixation, but even in frameless, we can use either an adhesive like a vitamin E tablet or bone drilled screws, which we already discussed in the morning, so that the imaging and the merging accuracy improves. So when you do a registration, the registration can be much more accurate, and you can reduce the errors. Normally what we do is what is called a surface or point marking, where we use anatomical landmarks like tragus, the nasion, the inion, or the tip of the nose and lateral canthus as pointers or a surface pointer for registration. So this is a picture to show you the bony fiducials. So you can see you can have all these bony fiducials, take a 3D image, and when you are registering, you can match these with the pointers. This is just to show you a tractography based sequence which I was talking about, so that you know where the tumor is and how the tracks are all around the tumor. So this helps us to reach the tumor safely and to do a complete excision and give better prognosis. So this is the kind I told you, because if you make errors in registration, then your navigation may not be useful, because the computer has to understand how the patient's head is oriented in relation to those cameras and the tracker devices. So if we make an error in registration, most important thing, we need to know that we have to be very particular and meticulous when we do this. So this is basically to relate the patient's anatomy to the radiographic data, and we have to register the image data with the physical space. Either you can use a tracker or paid points, and like I told you, we touch the patient's point and register with the planned position on the image data. Once you verify this and you are sure that you are in the accurate place, then you can proceed further. So this is just to show you the surface points like I told you. So usually we use these kind of surface points for marking. Once you do this and confirm, then what you can do is to take further points, which may be in terms of surface point. That means you can either use a pointer to take it, or they even have laser pointers with which you can mark multiple points and improve the accuracy. Once you do that, then you plan your scalp incision based on navigation. So this is the tracker device. So this is the striker tracker device which is adjusted to the Sugita frame. And once you do that, you have to have a device which tracks it. There are two types of technology that is used. One is called the optical and another one is called the electromagnetic system. They claim an accuracy of less than 2 mm as of now. So this is the optical tracking system that is the most commonly used. Both the Striker and the Medtronic Stealth Station use that. There is an electromagnetic tracking device available with the Medtronic, in which you really don't have to worry too much about the head movement. So these are the various devices that they use. So these are the microspheres that are available in the Medtronic device. So you can see that if you have preoperative fiducials, you can just correlate that with the MR and the imaging, and then the registration can be quickly and done accurately. So this is the laser pointer to use additional points that you need when you have to improve the accuracy of registration. In terms of transnasal, just one slide to show you that if you have not fixed the head in a transnasal surgery, the Striker, there is an available something called the mask. So you can use this to register, or you can even fix the tracker device like this with your navigation equipment there and the endoscopic instruments there, so that you don't come in the field. So this is one slide about spine surgery. Either you can have a ischial bolt, that means you have a device which is pushed into the ischial bone, and then you have this reflecting spears, or Striker gives you another kind of map which you can use to do that, or you have the spine holding clamps. Last two things. So once you do that, next step is to plan the surgery. I think that is the most important thing. You can do the scalp marking based on what kind of tumor you are doing and make sure you are in the right place. Once that is done, the next step is obviously to do intraoperative navigation. So these are all representative cases that we have done. So you can identify the lesion in 3D, make sure that you are in the right place. You can choose an approach, you can do a biopsy, you can do an excision, choose the gyri or the sulci that you want to enter, and prevent any kind of additional damage that will happen during the approach. So you can even do it for posterior fossa. I'm not going to go too much deep into it. That is another challenge, but definitely you can do that. So this is just to show you an endoscopic setup. This is just last slide to show you about navigation guided biopsy with the Striker. So once you have a thalamic lesion like this, you can plan the whole trajectory. It has a probe's eye view in which you have to match this crosshatch. And this is how it looks. So it has the device, which is a consumable which you may have to buy or reuse it. So once you have this, then it has got a predetermined needle. You can measure the depth and use a blocker and then do the biopsy. So the last slide about spinal navigation. So you can use it to put screws. So you can see in this.
So kindly conclude, sir, actually.
Yeah. You can see, you can plan the whole trajectory. This is an OAM integrated this thing, so last is the error, I'm not going to go too much into it. Brain shift, one last point, very, very important, is the limitation of the navigation system, because all of us know that once the dura is open and the CSF is out, there is a displacement of the brain and the navigation does not account for that, so we have to remember that. Most important thing is if you have an intraoperative imaging, then you can take another intraop image and upload it, and so that you can prevent that error also. So to conclude, anatomical knowledge, I think, is the most important, still is the gold standard. We know that navigation helps in planning safe approaches and improving the extent of resection. Most of the centers have it now, and we need to use it as a routine so that everyone who is doing it is aware of the procedure, and so that there is no error and it runs out as a smooth thing, so that even the learning curve becomes smoother and the time is also improved. Robotics and navigation is the future. Dr. Ramesh is going to speak on that. Thank you.
Thank you so much, sir. Because of the time constraints, we can't have any questions now. So I invite Dr. Ramesh Dodamani for his talk on the robotic guidance in the neurosurgery.
So at the outset, I would like to congratulate the Aiims Jodhpur team, Professor Jha, Professor Bhaskar, and Dr. Mohit, Mayank, and team for this wonderful congress. And the talks are also of excellent quality and then spaced nicely. So I'll be presenting
The guidance is finding some difficulty in communication.
the guidance is misguided. Yeah, something came up. Oh. Okay, thank you. So I'll be briefly covering about robotics, robotic guidance in neurosurgery. So this will be outline of my talk. I'll be rushing through the slides, so please bear with me. The frame-based stereotaxy has been already covered, and this is how it has progressed, and then currently we are at the Lexil frame. Again, frameless stereotaxy is not inferior to the frame-based stereotaxy, and then again, it is multiple studies have shown equivalent efficacy as well as accuracy of this thing. And robotics, again, after frame-based, now next will be the robotics, which actually has evolved. Actually, the first robotic procedure was performed in neurosurgery as a specialty, and then the urology and other specialties took over. So that was an industrial robot which was used initially for a biopsy. And then now there have been too many improvements, and currently all the robots which are available in neurosurgery are basically they provide a navigated arm for which is adapted to neurosurgery. And telerobotics is yet to come in neurosurgery, it's still in infancy. So these are the various procedures which are being done currently using the robotics. So I'll be covering the ones which we are doing at our institution. So epilepsy is a major chunk which we are doing with robotics, and then robotics have taken over almost all the open surgeries which we used to do in the past. So majority of our surgeries are mainly they have been converted to just lesioning procedures. So I'll be covering with this is the basic OR setup, where we have intraoperative O-arm with a robot. We have the latest ROSA robot, which is a second generation one. So as we all know, this is a classical case of gelastic seizures of hypothalamic hamartoma, which a child presents with laughing seizures. So in this, there have been evolution in the technology from initial beginning. There used to be resection of these lesions using larger craniotomies, and then it has progressed to minimal invasive procedures. Currently, most of the centers have been doing, even gamma knife has been described, and at our institution we have been doing radiofrequency ablation for this, and then in the Western countries it is mostly LIT, that is a laser-based lesioning for this, which have excellent seizure outcomes and with minimal complication rates. So as you can see here, the morbidity and mortality was higher with the open surgeries. Now it has come down, and this is how we do the surgery, where we just plan the disconnection. It's become a disconnective surgery rather than resective surgery, where we just at the interface we try to plan and then burn these hamartomas. The protocol is as usual at 74 degrees at 60 degrees centigrade. We use the Lexel pulse generator. This is a short video. I hope I'll be just running it, because this is a giant hamartoma in a 5-year-old male child, which we have done the same. We do the planning 1 day prior to the surgery and place it. This is a registration process using the ROSA, and then we use the twist drill. And the trajectories have been placed. Before lesioning, we do a intra-op OCT, and then we merge it with the pre-operative MRI and then confirm the trajectory. Once it is confirmed, we do the proceed with the lesioning, and then this is how it looks like in the post-op. This patient did well in the post-operative period. So with this, we have done till date around 17 patients, and one of the patients had he has a hypothalamic obesity. Rest of them have done well, and then 16 patients had a class 1 outcome following surgery. These are few illustrative cases where you can see a good lesioning here. This is a case type 1 HH. This is a type 2, this is again, this was a pre-op, this is a post-op. Again, here very nicely, which is in these cases, and this is a giant hamartoma which I already showed. This is one of the cases with which came for a redo, where there was a residual connection which we burnt again, and then patient had a good outcome. The next indication is basically the placement of stereo EEG. Stereo EEG, as you know, that the indications are standard, where there is a MR negative case, or there is a discordance between the investigations, or bilateral as well as multiple lesions where you want to localize a lesion to a particular spot. Technique-wise, we again use the same, these are the equipments. Because of the want of the time, I won't be able to show the video. So this is a video published in Neurology India webinars. You can go on YouTube, and it's a very beautiful and explainative video which you can have a better idea of. And this is an illustrative case which I'll be going forward. This is a case of, this patient had a FCD, that is a sulcal FCD here, as you can see. This basically requires a lot of preoperative brainstorming, but I am just showing you a screenshot in time. So you can see there is a concordance of SPECT, which is showing again the same region on the right side. And then the PET again shows a hypometabolism, as you can see here clearly compared to the other side. So this was a basically FCD, sulcal FCD, which he was a very engineer and a functional individual and did not want open surgery for this case. So basically we gave an option of placing the SEG electrode and then giving a lesion. So we placed the SEG electrode. Again, this is the patient. So we do a bedside lesioning. Like we placed the SEG electrode and then we did the lesioning in this patient at the bedside. So the same protocols are used. This is a post-operative scan where you can see the lesioning, which is seen right across the banks of the sulcus. So the FCD was involving the bank of the sulcus. But this patient subsequently presented again after 6 months with a seizure, and then he had to undergo open surgery. So then he agreed for the open surgery. Now coming to the periventricular nodular heterotopias, these are a very diverse group of very rarely, although rare entities, but they present with drug refractory epilepsy. You can see there is a bilateral heterotopia with the right predominantly involved. And investigations actually concur to the right side. There was a field effect also on the left side, left hemianopia. So we proceeded with this lesioning in these patients. These heterotopias are deep-seated lesions, and then going all across inside is with a open surgery would damage a lot of cortical tissues, and in these cases lesioning using a small probe is like a boon, and then they have good outcomes. As you can see here, we placed multiple trajectories and then even perpendicular also to cover up for these lesions, and then this patient had a good outcome. Similarly, there was one more patient with a solitary heterotopia, as you can see here in the ventricle. Again, we did a lesion. We have total 6 patients till now with heterotopias which have been undergone RFA, and 2 of them had a SEG guidance because there was certain confusion with the site. So out of these, 50% of them had a class 1 outcome, which is in par with the literature till now available. Now coming to the endoscopic hemispherotomy. Hemispherotomy has been described, endoscopic hemispherotomy, as we all know, Dr. Sharath had pioneered this technique. We do the vertical technique using the interhemispheric approach, and then here the robot acts as a holder, which is, there is no fatigability, and then it can hold the scope for longer duration. And using this technique, we have performed more than 40 cases of hemispherotomy. It's been published, and again the video is available on Neurology India webinars, you can go through. Then comes the robotic thermocoagulative hemispherotomy, which is the recent technique which we have described for the first time in the world literature. Again, I'm not going into the details, you can go through the paper which already we have been published. And these are the post-operative images. You can see a beautiful disconnection. And this is one of the cases which we did, was 5 months old baby and then 6 years old kid, both right and left hemispheres. Nice disconnection. This is overall the robotic epilepsy procedures which we have been performing in our institution. Now coming to non-epilepsy cases where VP shunt has been one of my favorite indications, that is especially the IIH, where we have done robotic guided VP shunt. Again, this is a video, I won't be playing, sorry for that. So navigation guided shunts have been described in the literature because of, as we see with a lot of our residents also, even the senior person putting a shunt and going haywire, which we never expected. So image guided has no role in patients with hydrocephalus, but those with small and dysmorphic ventricles, definitely it has a role, and then it should be used. And we have tried, maybe this is, we are the second group which published a robotic guided LP shunt. This is one of our patients who underwent a LP shunt because of the chinked ventricles in these patients, and then she developed a secondary chiari. So we blocked it, and then again we did a robotic guided shunt. We have done till now 7 cases with good outcome with the first hit. There was one patient with malposition, but that was because of intraoperative movement while tunneling, so that was an issue. But after that we have modified it. Then we have, these are a few illustrative cases where you can see the shunt well in place. Again, it's a video available, you can go through. For psychiatry, we have done around 3 cases of bilateral cingulotomies for OCDs using robotic guidance, and with, I'm just concluding. So with good results, with a 50% reduction in the VIVOC score, and then patients have done well volitionally also. So this is my team. I would like to thank Dr. Manjari and Dr. Sharath for being a supportive force. And finally, robotic guidance is safe, minimally invasive, and then probably it has become an integral part at our institution, at least for epilepsy surgeries. And hope in future tele-robots will come up in a big way where you can operate remotely sitting at some place in another remote place where there is no technical expertise available. So that is what is the future. Thank you very much for the patient listening.
Thank you, Ramesh, for this fantastic personal experience and taking us to a beautiful lucid presentation. Now we request Dr. Natesan Damodaran. Me and Natesan were the co-fellow of Dr. Suri on the Aiims. So he's speaking, he's doing a good job in functional neurosurgery, searching for a needle in a haystack, utility of image post-processing in DRA. Till it gets connected, on behalf of the organizers, I beg your attention for the gala dinner, and it looks to be a very, very picturesque location for a dinner. It's a palace.
If you don't finish on time, the palace will not be open.
Good evening, everyone. I thank the organizers for giving me this privilege to present here and for accommodating me on this evening. It is scheduled for tomorrow. Okay, getting to the talk, we're talking about the utility of image post-processing in drug-resistant epilepsy. So we'll go through this, like why we need post-processing, what are the types, and what are the visualization tools, and how to integrate the what we get into the SEG and surgical planning. So the Holy Grail progenic focus. So we have the success in epilepsy surgery is the effect which produces the anatomo-electroclinical local. When one of these fails, it can be the semiologist localizing, or the EEG has a diffuse onset, or an MRI does not show the lesion, then the safety ring is broken. So that's when we are stuck. So many times when we say an MRI is negative, what we are saying is we are trying to look at the image visually and we are not able to really see what is there. But does it mean that MRI is really negative is the question it asks us. So then, what are the ways we can try to tease out the information from the MRI? One is, as we know from experience, from the greater availability of 3 Tesla MRI, we know that the pickup rates are better. And with the recent publications with the 7 Tesla, we know the greater resolution, we are going to have better pickup rates of all the lesions which we are missing right now. And then second is to start using the standardized MRI protocols. And then we can start using special sequences like MP2 Raj and T2 relaxometry as when required. And then definitely the re-review with the multidisciplinary team and the neuroradiologist. And then finally is the MRI post-processing and the visualization together. So the harness protocol given by LA Neuro Imaging Task Force is like going to be the foundation for us looking at the MRI and also for the post-processing. So it's very essential that we acquire image in the harness protocol. So the MRI post-processing has this advantage that it is a computer or a computational method which is doing, so there is no operator dependence on it. And it does not require any of the clinical information or the EEG. So it's not dependent on, again, somebody looking at the EEG or looking at the semiology to say, okay, this is where you have to look for the image processing. So when we come to the MRI image processing, see, in this we are going to cover the MRI image processing, we are going to cover the PET processing and the SPECT processing. So in MRI image processing, we are going to be looking at how do you do the post-processing for FCD detection and how we are going to do the post-processing for temporal lobe epilepsy, especially for the hippocampus. So in FCD detection, in the processing, we look at the gray matter thickness, gray-white blurring, extension of the gray matter into the white matter, and the intensity variations and the sulcal depth. These are what considered in the post-processing. So this is one of the common tools which is being used. First, we're looking at the text analysis developed by the Bernasconis. So here we develop a ratio maps from the gray matter thickness, relative intensity, and the gradient. And by looking at the ratio map, what you're seeing there, and in here, we are able to identify orbitofrontal FCD, which was not evident to us earlier. So this was earlier. After the processing, we had to look at in the ITK Snap or some other visualization tool which we used to use. But then now we have an automated version of this that's like the AI which has integrated this, and we have a deep FCD which is able to do this. And the other widely used tool is the MAP18, like that is the morphometric analysis program which was released in 2005, and it has multiple versions, and the recent version is the MAP18, where they use the junction image and the extension image, and together it gives an output like this, where we can see a lesion, a very small lesion which is picked up at depth of a very small abnormal sulcus. Like the junction image will be having an hyper intensity here, and an extension image is going to have this, and we have to trace it back to the T1 image. So the currently available widely sort of used tools are, one is the MAP 18, other is the Deep FCD, it's an AI based, and the MELD, which is under development, it's also an AI based tool. And coming to the temporal lobe epilepsy image post processing. So the reason why we need in temporal lobe epilepsy is one is to identify the hippocampal sclerosis if it's not obvious. So for that we are going to be looking only at the hippocampal volumetry. I'm not going to discuss the hippocampal sclerosis as such. So in hippocampal volumetry, there are two places where it's useful. One is at the MRI negative temporal lobe epilepsy. Other is when we have a bilateral temporal lobe epilepsy. So in MRI negative temporal lobe epilepsy, that's like quite common. 1/3 of the patients with a temporal lobe epilepsy are negative, and the histology is quite heterogeneous, and they seem to have a different epileptogenic network. So that means they have to be looked at differently. And we see that when operated without a post-processing or an additional information, then the surgical outcome falls to 51% from a 75% when it's in hippocampal sclerosis. But then when we have a PET hypermetabolism concordant, then the outcome again comes up to around 75. But then if it's a discordance, we have to rule out a temporal plus or a pseudotemporal epilepsy by doing an intracranial EEG. But when you come to a bilateral temporal lobe disease, that is when we have bilateral onsets, a simultaneous bilateral or multiple on either side, then hippocampal volumetry is very useful compared to the PET or SPECT or other non-invasive methods. But if we are left with a normal hippocampal volumetry, then we have to go forward with an intracranial EEG. So the tools which are available for us. So FreeSurfer, it's a very robust tool, but it has it's very difficult to learn. MAP 18, it is also specifically has tools developed for hippocampal volumetry. This is an output from the MAP 18, where we can see the hippocampal volume of this patient, which is in the midline, is in the normal space. If it had been on the left side, it would have been signifying hippocampal sclerosis. If it was moved to the right side of the line, it would have been the right side hippocampal sclerosis. The other tools will be HippoSec, 3D slicers, and of course the earlier, for a long time, we have the manual mapping. It's coming to the PET post-processing. So the simplest thing what we can do is have a proper co-registration of a PET with MR co-registration. There are several tools. Identifying the appropriate tool by which we are able to co-register and see the anatomy, underlying anatomy closely, will help us to identify the lesion underlying that, when we can go back to the MRI. We can see here an hypermetabolism, and because it's strictly registered, we are able to see the MRI. But then we went ahead a few steps where we thought not just co-registering, and if we can subtract the hypermetabolism of one side of the brain to the other, then we might be able to develop an asymmetry index. So here we did the co-registration of the PET onto the T1 MRI, and then what he did was he did the symmetrization of the brain, and then we did the asymmetry of the PET. So through this, what we could get was the asymmetry index, so where it could localize to the lesion, the hypermetabolism to that specific lesion, where all the other information which were distracting us are getting removed. So in that we got a Z score of 4, where at that score the sensitivity is 95 and the specificity is 82.3. Coming to the SPECT post-processing. So SPECT is basically we have to do 2 scans. We have an ictal perfusion SPECT, just be done within the 15 seconds of the onset of seizures, and then we have an intraictal SPECT, and which has to be done more than 24 hours after the ictal SPECT and within 2 weeks. And then we are now left with an option whether we can subtract the ictal and the intraictal SPECT with the co-registration onto the MRI. It was described as early as 1995, 1998. And then recently we have a lot of SPM statistical tools, which also have proven to be as good or even sometimes better than the SysCom. So then we can also do a PET and a SPECT co-processing, where we can co-register the ictal SPECT and the PET and subtract the hypermetabolism of this ictal SPECT from the hypermetabolism in the PASCOM of the PET. So that leads us to a PISCOM. This is under evaluation and it's not yet validated. So coming to the last thing is the volumetric tools, which can be used are the free surfer, 3D slicer, and a lot of SPM based volumetric tools are available. And these can be easily downloaded from this website, which is a repository of a lot of neuroimaging tools. It is the NITRIC. And we had a patient who had MRI negative. We did a MAP 18 and it showed a small lesion there. And MELD, another post-processing AI tool, also showed a similar lesion there. And PET PASCOM was showing a hypometabolism in that region. So we went and implanted that region. And so we can see here the electrode which went through that VBM lesion at the onset, and the PASCOM, that is the PET hypermetabolism, also were covered. Those regions were covered. So those were having a little slightly delayed onset. And then this is an intraop image of this abnormal sulcus, which was resected, and it turned out to be a FCD2A. So finally, to summarize, when you have done an MRI with an epilepsy protocol, and if you don't see a lesion, then we have to, first thing you should do is to make sure there is we don't have excessive artifacts and the correct epilepsy protocol has been done. If that is verified, then we can re-review all the information based on, get back to the MDT and review the MRI. And if that also is negative, and definitely then we need to proceed to the post-processing as we have described. And if available in other countries, we have 7 Tesla MRI. And then based on all this, we can form a surgical hypothesis and go forward with a stereo EG or a resection directly based on what we have got. Yeah, thank you.
Thank you very much, Dr. Natesan, for helping us find the needle in the haystack of radiological investigations. I'm sorry we do not have time for any further questions. And for the last talk of this session, we have a batsman from the home ground, Dr. Mohit Agarwal, who will be telling us about volume rendering techniques as a navigation tool in a resource-constrained setting.
So after these talks, utilizing expensive tools as neuronavigation and difficult to understand post-processing, I'm sorry, but I'm here to tell you that in resource constraint setting, you don't really need nothing more than a DICOM images and a laptop running Windows to set up navigation for your OR. Yeah, so my talk will be VRT as a neuronavigation tool in resource constraint setting. So conventionally, when we go to localize a tumor intraoperatively, we use the Taylor-Horton lines, surface anatomy, using the gyra and the sulci, and CT and MRI reconstruction in the surgeon's mind. So that can be quite difficult sometimes. As what are the solutions that we have traditionally come up with? Other of course the navigation tools, which we all heard in detail. Ultrasound, which can be cheap, which is a cheaper technology, but its use can be subjective, and there is a certain learning curve. Intraoperative CT and MRI, which is again quite costly. So we as a department, while facing these similar problems, we came across like volume rendering as a way of navigation. So volume rendering is nothing but a type of visualization technique in which a stack of regularly spaced 2D images are viewed in 2D and then converted into the 3D. So what are the softwares which are available to do this? These are all easily available and freely downloadable on the internet. We are using the Radiant software in our practice. So this is the typical workstation where you can see all the images of the patient are loaded in the DICOM format onto the workstation, and there are a set of powerful tools available on this top bar, using which you can manipulate these images. So we can think of the conventional images as the conventional maps, which were usually available for navigation before the Google Maps made its appearance. So like that, to navigate inside the patient's brain, we need to know each and every gyra and sulci properly, like it is available in the Google Maps. So VRT is nothing but a easily visualizable roadmap to the lesion inside the patient's brain. So on the click of, it should be as easy as on the click of a button, you should be able to reach your destination. So prerequisites for operating 3D VR images are not much. You just need a DICOM viewer software with a VR tool like the Radiant, and CT and MR images in the DICOM format. The images should be 1 millimeter contiguous non-overlapping cuts. And we have seen that FLAIR images are best for visualizing the gyra and the sulci and the surface anatomy, while contrast images are best for making out the contrast enhancing lesions. Of course, you need a basic computer running Microsoft Windows 10. So the uses of VRT that we have seen are it's quite useful in surgical planning in simulating a craniotomy, and when you visualize the preoperative morbid surface anatomy of the patient, you plan the shortest, safest trajectory on the computer before you open up the patient. It is beneficial for trainees to better appreciate in 3D than in 2D. So this is just a short video which will demonstrate the technique. So this was a small peritrigonal small deep-seated lesion which was contrast enhancing. We loaded up the images onto the Radiant workstation, and using these tools, we will actually just utilize a contrast enhanced image. We'll make a 3D of that image, and using this windowing technique, we can actually make out the lesion. We can make out the 3D anatomy of the patient's head on our window itself. We can adjust it according to the view we want, and then further again we can maximize or minimize the lesion. Further windowing of the technique using the same scroll button will take us deeper further down to be able to see the various intracranial contrast enhancing anatomy, like these dural veins, which we can visualize and plan the interhemispheric approach also if needed. We can now make out the lesion clearly, the peritrigonal lesion, which was contrast enhancing. It can be made out quite beautifully, and its distance from the surface can be measured using the ruler tool. Again, we can rotate the image to the sagittal view and again make out this lesion. We can mark it out inside the brain. Again, using the windowing technique, now we have projected the lesion onto the surface, and now we can make out its relationship to the pinna. So we don't need expensive fiducials to do that. We can use the God-given surface landmarks. Again, the distance can be measured. We can save these images and print them out and take them to the OR. Now, this was for the lesion per se. What about the approach to the lesion? The approach to the lesion will be decided using the FLAIR images. Again, making a 3D of the FLAIR. Again, using the windowing technique, we can now make out the surface cortical gyra and sulci, and we can see that there is this Y-shaped sulcus which is near the lesion, which was earlier marked in the contrast enhanced image. Scans. This Y-shaped sulcus will be an entry point. This is the operative view. This is the section, and we can beautifully make out this Y-shaped sulcus over here, which was visible in the FLAIR images. We did a transsulcal approach, and this was the post-operative MRI showing complete resection. So we have published these findings also, and this is a QR code which will lead you right up to the this video which I just showed. And I just wanted to project that you don't need very expensive tools for basic neuronavigation to guide us. But a fool with a tool is still a fool, so you need to be careful while using these techniques. But yes, it is still doable. Thank you.
Thank you very much, Dr. Mohit. I think we have time for one quick question. Perhaps the questions will come up as we go towards the gala. I must thank all the speakers for this, and all the audience for your presence and thought-provoking questions. Thank you very much. We move on now to the last session, and I think the chairpersons would change.
Good evening. We now move on to the last session for the evening, that is paper presentation. I would like to call the chairpersons for the session, Dr. Ari Valagan, Dr. Krishna Kumar, and Dr. Ramesh Dodamani.
Yeah, I hope we'll finish this session as fast as possible.
This is the last session, and we straight away begin with the talks. I would invite Dr. Navneet Singla. He will be speaking upon the effect of extent of hippocampal and amygdala resection on seizure.
Yeah, as I asked few questions in today's surgery,
Same, I did some study on my patients to know how much amygdala and hippocampal resection is necessary to have a better surgical outcome without any increase in morbidity of the patient. Still, we don't know what is the exact amount, what is the optimal amount of resection of hippocampus or amygdala or tail or body of the hippocampus, how much should be removed and what is its correlation with the seizure outcome. So our approach is anterior temporal lobectomy with amygdalo-hippocampectomy, same as which was demonstrated in today's session. These are 40 patients in which 22 were males and 18 females, and their mean age was 27 years, and seizure duration was around 12 years, and they have long duration of seizure, and most of them they have early onset of seizure in their teens and early childhood. And they have frequency of seizures as high as 6 per day. And there were 24, out of these 40, 24 were right-sided MTLS and 16 were left-sided. This is the typical radiology of MTLS with hippocampal sclerosis, and there is degradation of insulated temporal horn, and flare changes. We have follow-up of 2 to 4.5 years, and mostly of these patients, the surgical outcome in the form of seizure outcome is Angel class 1 is 85%, Angel class 2 is 10%. 16 patients are seizure free after stopping all the anti-epileptic drugs, and 22 patients are seizure free or not, or they have a few non-disabling seizures and on tapering. That too was on tapering of the drugs. Two patients they had recurrence after initial control. So I'm not going into detail of neuropsychological assessment because of time. There was improvement in 75% of patients. There improvement of neuropsychological improvement, and this was more on right-sided surgeries. And when we analyzed the post-op MRI in these patients, there was complete hippocampal head and body resection was in 90% of patients. And in terms of tail resection, the 65% of patients had partial tail resection, and there was no resection of tail at all in the rest of the 35% patients. There was complete amygdala resection in 30% cases and partial amygdala resection in 70%. This is a few post-op images showing partial amygdala resection with the total hippocampal resection. All 34 patients with complete seizure control had complete hippocampal resection, and they fall into Angel class 1. And if we see universally, the 94% of patients with complete hippocampal resection, they had Angel class 1 outcome. But only 50% of patients with the partial body resection of hippocampal, they had Angel class 1. There was no effect of amount of tail resection or extent of amygdala resection on seizure outcome. So even with when we correlate with the neuropsychological assessment, there was no correlation with the extent of resection of hippocampus or amygdala or tail resection with the neuropsychological outcome. Rather, there was an improvement in neuropsychological assessment in, as I told, in 75% patient, maybe because of good seizure control and tapering of anti-epileptic drugs. So complete resection of head and body of hippocampus is must for maximum seizure control and cognitive improvement in MTLS. Partial or complete amygdala resection are equally effective without cognitive impairment. Tail resection has no role. So, and role of extent of cortical resection is need to be assessed. So that was not part of this analysis. Thank you.
Thank you, Dr. Navneet. Any questions? So, Dr. Navneet, one question. So, you said partial tail resection, complete tail resection. So, what is your goal of surgery? Because you analyzed how much you resected in various cases. In every case, your intent would be to remove a particular amount of.
We are going.
Your intent of hippocampal resection?
Yeah, we are going purely on the measurement. We'll resecting around 2.5 to 3 centimeter from the head of the hippocampus. So if it is not including the total body resection, we'll go further till the body resection. If it including the body resection as well as the tail, then we'll remove till that. Mostly till the 3 centimeter from the interior-most part of the head of the hippocampus.
Okay, thank you. Can we call the next speaker, Dr. Raghu Samala? He's going to talk on setting up functional neurosurgery practice in private setup, lessons learned.
मीन्स वो और भी तरीके हैं. You want to be really brutal about time, you tell please load your presentation here by this time. If you don't load, there is no talk.
Good evening, everyone. Thanks for the opportunity by the organizing team. So I'm going through what I faced the challenges while establishing an epilepsy and functional unit in terms of a young neurosurgeon. So I finished my epilepsy and functional neurosurgery with the flying colors, but when I entered the independent practice, I was standing alone. So when I was working as an epilepsy fellow, we used to give the dates to the patients. There's so many patients and the workup and directly come to the surgery directly. So when I went to the private practice, there was no patient at all. And as I was all alone. So there was even knowledge gap because when I was doing fellowship, every patient was worked up by the epileptologist. When I was in private practice, there is completely opposite of it. So I have no knowledge of EEG and workup of the functional cases. And there was a difficulty in finding or dedicated epileptologist and infrastructure. And initial first 6 months, it was like... So after that, we started working on it. We find a movement disorder specialist as of now, and we collaborate with other hospitals. And now we have a team of 3 epileptologists who are very passionate and almost contemporaries to me. And we are building the epilepsy and functional team now. So what I realized is patients have many of the patients they are eligible for the surgery, but they do not have the awareness that the options exist. And even many of the pediatricians and physicians have the same opinion. So we try to build that gap, decrease the gap. Like we conducted multiple CMEs in the district centers, workshops, conferences, patient awareness programs. But to be honest, none of these work well with us. And there's another problem is the resource scarcity. So because most of the patients are poor and epilepsy workup takes some significant amount of money, and that DBS is associated with a huge cost. So to decrease that, we made single consultation for all of the team, like epileptology, thus decreasing the cost to 1/3 workup. And we discussed with the hospital to helping the patients. And the only thing was I was very fortunate is my hospital provided good equipment except stereotactic frame. We have O-arm, semi-robot, autoguide, which was Medtronics, and all of this. So initially I felt that I need a stereotactic frame. Now I'm so acquainted with it and used to it to use the autoguide using fiducial registration to increase the accuracy. That experience which I had during my fellowship working on the ROSA, that helped me here. So this is the amount of accuracy we are getting at our center right now using bone fiducials. The target like almost completely. We did around 18 cases, of which 16 patients were drug refractory epilepsy, predominantly hemispherotomy. And we did one frame-based DBS and palidotomy. We are using AutoCAD. So these are some of the examples. This is perinatal insult undergone hemispherotomy, cortical malformation undergone hemispherotomy. This is focal eloquent area resection of focal cortical dysplasia. This is hypothalamic hamartoma using AutoCAD radiofrequency ablation. This is the same, the planning. So this is a post-op scan. This is the one DBS we did with the frame. So we look at patients and bridging the gap between the finding solutions and more academic and research. We should have a good. I learned is one step at a time. We will hit there. So this is my team.
Thank you, Dr. Raghu. And what are the social constraints that you felt while setting up these programs?
Yes, sir. The many patients, first of all, they do not know that these options exist. To be strange, one of my patients, once we advised the patient about the surgery, he went to a Babaji and asked this, like, how is this surgeon? The Baba told him that the surgeon is good, go ahead, and he came and operated him. So this is the scenario. The perspective which we see in the institute is completely different from what we see outside. And there's a referral system is there. There are many other social elements are there which we have to tackle it. But this is doable, but it takes just time.
Thank you. Thank you so much. Dr. Nitish Agarwal and his paper on awake target analysis and clinical outcomes.
Yeah. In the presentation, I would just like to thank the organizer and the members of the office bearers of the Issfn for this opportunity to talk about this work. Download. Subsequent speakers in one laptop. Avoid this. In that. I hope there are no videos. Load the PowerPoint.
We don't have already. These are already loaded. We can display from there only. वो लैपटॉप ही लगा हुआ है ना, ठीक है। ये तो सबका है।
Alright, my name is Nitish Agarwal and I'll be talking about this study that we conducted during my time as a fellow in Halifax, Canada. It is basically about awake versus asleep subthalamic nucleus deep brain stimulation in Parkinson's disease and a comparison of the accuracy by the use of three-dimensional target analysis as well as a comparison of the clinical outcomes. Don't have any disclosures. So traditionally, the accuracy in awake versus asleep DBS has been, there have been a number of studies that have looked at this, and most of these studies suggest that the accuracy is similar. But the traditional method of accuracy assessment, it basically measures the deviation of the final target position from the planned target position. But the problem with this method is that it leads to the introduction of a bias when we compare awake versus asleep DBS and when we are looking at the accuracy of these two. So, the surgeon would intentionally sometimes place the plan depending on, but this is not the case in asleep DBS. So theoretically, this means that asleep DBS would always be, more accurate. So just to target this bias, what we did was that we used three-dimensional electrode localization and target analysis. Parkinson's disease, who had asleep ST and DBS, and we also looked at like motor, quality of life, cognitive outcomes, adverse effects and complications at 1 year follow-up. So we did this using lead DBS and lead group toolboxes, which are basically MATLAB-based toolboxes, which enable three-dimensional electrode reconstruction as well as localization of the electrode contacts. And then we can simply compare the number of electrode contacts that are residing in the target space, that is the STN, in both the groups and look at what is the final outcome. So I won't go into the details of that. Coming to the methodology for motor outcomes, the methodology for clinical outcomes, we looked at the quality of life and motor outcomes by PDQ-39 and UPDRS scores at 1 year follow-up. We also looked at the cognitive outcomes by using a battery of 10 tests, with 2 tests being from each of the 5 cognitive domains. And then coming to the results, both the groups were similar in terms of baseline characteristics. They were also similar in terms of the mean baseline scores. And this picture in itself is a result which shows it is a three-dimensional representation of the electrodes from both the groups. And it shows that we can already see that the electrodes in the asleep group appear somewhat outside the STN and laterally placed. And our target analysis actually showed something similar. It showed that when we looked at the number of electrode contacts in the STN, within the STN, in the awake group, we found that there was a significant difference as 80% of the contacts were present in the STN in the awake group as the region where it mattered. When we looked at the motor STN, there was no significant. At the 1 year follow-up scores and subscores as well as the PDQ-39 scores, there was no significant difference between the two groups. And looking at the cognitive outcomes, we found that there was a trend towards worse cognitive outcomes in the awake group as compared to the asleep group, as close to 50% of the patients had a worse cognitive outcome or a significant cognitive decline. Coming to the complications and adverse effects, the complications were more or less similar in both the groups. The most common complication, or rather the adverse effect, was the behavioral change that was similar in both groups. Then coming to the conclusion, three-dimensional electrode reconstruction, localization and target analysis can actually provide invaluable anatomical and physiological insight into the functioning of deep brain stimulation. An intraoperative macro stimulation which is performed during standard awake DBS surgery, it may be beneficial in targeting the entire STN space, but not specifically the motor STN with greater accuracy. And evidently, we did not find any difference in the motor outcomes or quality of life when we looked at both the groups. And finally, awake DBS displayed a trend towards worse cognitive outcomes in our patient population. Thank you. I'll be happy to take any questions now.
Thank you, Dr. Nitish. How do you explain worse cognitive outcome in an awake DBS?
Yeah, thank you. Thank you for asking the question. When we looked at the contacts, the electrode contacts, when we look at the electrode contacts in the associative and the limbic STN, we see that there is a significant difference between awake and asleep groups. So there is some literature out there where they say that these regions have hyperdirect pathways to limbic system, to hippocampus, to parahippocampal gyrus, to prefrontal cortex, and which is why on stimulation of these regions in particular, awake group in particular, we can have more cognitive decline and more behavioral change.
But this stimulation is a very transient, temporary stimulation which happens over a period of few hours. Will that explain cognitive decline?
So this alone may not explain it, but having said that, there are other hypotheses that people have put forward. When we talk about the Galaxy trial, they came out with the hypothesis when they were writing this paper. In the introduction section, they have mentioned that one of the reasons is also that many of these patients go into the surgery awake, and they are anxious and they haven't taken their medications, anti-Parkinsonian medications, which in turn can lead to post-operative confusion, which is actually a risk factor for worse cognitive outcomes in the literature. So that is also one of the.
Where is this study done?
The Galaxy trial. It was published
the work you presented, you said you were a fellow at that time.
Yeah.
So where work is done in which hospital?
So this work was done during my fellowship in Canada, in Halifax, in Canada. This was QE2 Regional Hospital and Dalhousie University.
I had one question and one comment. The comment is that the new software of Alpha Omega software of Medtronics can identify the motor STN and in comparison to the limbic STN. Second question, the question is, were these non-directional or directional leads?
So,
if it's a directional lead, then the whole comparison becomes infructuous.
So we used in the initial period, some of the electrodes that were used, actually in two of the patients, we used Medtronic leads. In majority of the cases, directional Boston Scientific Cartesia leads were used.
Directional or not?
The ultimate reconstruction you do and see patient and relative. Sometimes when we stimulate, there are some AEs which occur, which deter you from increasing the current or go to subsequent contacts or go for interleaving.
Yeah.
So isn't it too much believing in some software and some images? Where you can, in the normal MRI also, due to artifact, you don't know where exactly the lead is.
Can I remind the chair we need to attend something up?
Thank you.
Talking about just this tool, the lead DBS.
Thank you. Awake brain parts for unresectable high-grade.
Frameless optical versus electromagnetic. Brain biopsy sometimes patient presents with unresectable tumor tolerate prolonged awake regime because of poor KPS and other comorbid conditions. Brain-based biopsy was earlier until standard, but now more disease can be very stressful or anxiety. So, do and data were collected from retrospectively from operation notes, neuropathological reports, and post-biopsy scan was done to know the adequacy of the biopsy, and post-biopsy histopathological reports were collected. So Medtronic stealth system S8 was used, an axiom site emitter was used for electromagnetic, and registering the navigation took 5 to 8 minutes, and operation time was 55 minutes for optical and 46 minutes for electromagnetic. KPS score was from 40 to 60. So this is the optical biopsy set which can be disposable or can be used multiple times. This is the electromagnetic site mount emitter which is placed behind the patient. And EM scalp mount tracker was used with and a stylet with introducer. The tracker was fixed with the screw on the scalp. So these are few of the lesions which are unresectable, and also we want to do awake biopsy because of the eloquency. So the mean diameter was 52.45 millimeter. 70 lesions were situated supratentorially were undergo biopsy, and adverse effects were noted. Pathologically, the reports were obtained. So out of 76 biopsy, 44 were optical and 32 were electromagnetic. 68% provided definitive diagnosis, out of which 37 were optical and 28 were electromagnetic. So there was slightly more efficacy in the optical method. There was ICH in only one patient, and which responded to conservative management, but no significant complication was noted in both the procedures. So these are the procedures, and the p-value was almost similar to both the methods. So statistically, there was no much significant difference. Only accuracy of difference of 3% was noted in the electromagnetic group, which was slightly less. Operation time was also similar. The preliminary study evaluated the effectiveness and safety of the frameless optical navigation with that of the electromagnetic, and in terms of diagnostic yield, the results were almost similar, like 94% for electromagnetic and 97% for optical. So frameless navigation is now an emerging neurosurgical procedure, and that has shown relatively better outcomes. Unlike frame-based stereotactic biopsy, which requires the use of a rigid head frame, frameless navigation biopsy does not require the patient's head to be immobilized. So a very less operative time, and accuracy is also similar. The axiom, the electromagnetic axiom guided navigation also is similar to the optical, but in frame-based biopsy, the patients usually experiences pain, which can occasionally make the procedure impossible to perform in certain cases. Electromagnetic guided biopsies can be used for periventricular lesions with the trigger, and also without entering the ventricle, and also in the sphenoid lesions. So frameless biopsy can be used, is preferred because it is less painful and patient can tolerate it, and secondly, it does not require the referencing of the navigation system with that of the surface data from the patient. Lastly, the electromagnetic navigation is preferred. Optical navigation is preferred over electromagnetic, as the accuracy may be slightly lesser for smaller and deep-twisted lesion in the electromagnetic due to the lack of the proper biopsy guided device. Thank you.
Okay, thank you, Dr. Binoy. We'll go to the next paper. Thank you. Can we call Dr. Himanshu present on nucleus accumbens DBS, first psychosurgery for schizophrenia in India?
Good evening, everyone. So this is the outline of my presentation. We will be discussing the neurobiology, trying to understand the schizophrenia. We'll be discussing regarding this case, and then discussion and your views on this.
You have to restrict to 4 minutes, sir.
Yes.
Your time.
Yes, sir. So whenever as a neurosurgeon we look at any disease, we want to know where does the lesion lie. For that, we have to understand the functional brain networks. This has helped us in understanding the movement disorders like Parkinson and dystonia. So of the 7 networks, we have found that it is the salience network which is quite significant. Salience means significance. What does a salience network does is whenever you are thinking something, your default mode network is active. And when you see something that you say, oh, this may be significant, then your salience network assigns significance to it, or it rejects that significance. And then you can you can actually divert your attention to that proper thing, and then you can perform some task. So the salience network is kind of like it applies significance to a sensory stimuli or an internal thought also. So there is always a switch between DMN. DMN deactivates when you see something significant, and salience network gets activated. So now this salience network is modified by mesolimbic and nigrostriatal dopamine system as like any other CSTC loops. Now it is postulated that what dopamine does is dopamine acts as a filter for the CSTC for the salience network, so that it can filter out some unimportant area, and it can. What happens in psychosis? In the patients who are with psychiatric conditions, it has been noted that salience network is hyperactivated because of excess of dopamine in the system. And hence it results in symptoms of hyperdopaminemia, like positive symptoms, which are hallucinations and delusions. Reduced dopamine because of antipsychotic medications or some other things can result in negative symptoms, and later on lack of motivation and cognitive symptoms. So the abnormality that has been found in schizophrenia is in the chronic patients of psychosis, we have seen that there is gray matter loss and there is dopamine excess in all the system. And hence it has been also described as the wind of psychotic fire, where it's an excess dopamine which causes psychotic symptoms. So what can we do about it? Where can we intervene? Before that, you understand that there are 4 hypotheses. So what happens is for you to focus onto something, you have to deactivate the default mode network. There is inadequate deactivation of default mode network. That is one hypothesis. Second is hippocampal hyperfunction, which leads to excess of dopamine. Third is reduced pathways of reduced striatocortical and striatohabenular nucleus dysfunction. So various structures have been tried. We have so far in literature seen 13 cases who have been operated for schizophrenia into kind of 4 different targets. For us, this patient was an African boy who was 28 years old, suffering from schizophrenia for the last 13 years, with predominant positive symptoms of visual hallucinations, delusions, and with social isolation, social withdrawals from last 8 years. So he had referred here for neuromodulation. As with the Mental Health Act of 2017 in India, we before performing psychosurgery, we have to obtain an approval from the government. So we sought a government approval, and the target was chosen as the nucleus accumbens. I will not go into details of nucleus accumbens, but you can see that nucleus accumbens is a ventral nucleus. It is a part of ventral striatum located where the putamen and where the globus pallidus and caudate nucleus converge. So we localize the nucleus accumbens. We will be uploading this on a paper, so you can read the details of this. It also has 2 important structures in the core and the shell. The entire surgery was performed in general anesthesia because this being a psychotic patient could not withstand anxiety. And these are the trajectories, and we were able to target it well. And which you can see that there was only less than 1 millimeter precision. And patient did well. In the post-operative period, there was lesioning effect, which was mentioned by the patient on post-operative day 2, as that he felt the hallucinations were different. He could now see that they are still present, but he could see that they are not important anymore. They are somewhat fuzzy. After that, we activated one side of the lead on post-op day 2, second side of the lead on post-op day 7. After second lead activation, he had a brief period of anxiety, so we reduced the current on the second side, that is the right side. And after which he was fine, and post-operative day 15, a final assessment was done, in which we saw that the preoperative PAN score, that is positive and negative symptom score, that had reduced from 26 to 8, negative score from 18 to 7. So overall he had 69% improvement of positive symptoms like delusions and hallucinations, and 61% improvement, overall 62% improvement in the immediate post-operative period. This was done by a team of myself as a neurosurgeon, psychiatrist and psychologist. In discussion, we have a lot of targets, but nucleus accumbens appears to be the most encouraging target. More studies needs to be done in this research. There is a lot of burden, as we can see by many papers in India, of the psychotic diseases, and
your experience will be valuable in this regard because it's very important for these patients. Thank you. As I can see, the patient described on the day 15 that, I feel that I have now new strengths that I can pull on for the rest of my life. And I think we all can feel that the same once we go ahead with this. Thank you.
Thank you, Dr. Himanshu. I think we'll move to the...
I have a brief comment. I think we need to be a little careful about when we are presenting a data on one patient.
Yes, sir.
And it's a very short-lived data. I think this case has not been done for less than a month or a month and a half ago.
Month and a half now.
Yeah, so I think we need to be a little careful about data presentation.
Absolutely, sir. We need long-term follow-up.
Yeah, thank you. We'll go to the next.
One last comment. The government of India actually has, you need to have a mental health board review.
Yes, sir.
Before operating on all these patients.
Yes, sir.
So, is it different for foreign patients? Is it the same for foreign patients?
It's the same for foreign patients because these patients come on the basis of medical tourism visa. Because they are getting operated on the land of India, so they will be again reviewed by the same board of whatever the hospital you are visiting in the same vicinity, State Mental Health Board.
No, the State Mental Health Board has to be nominated by the government.
Pardon, sir?
The health board has to be nominated by the government of the state where it is. And it is not supposed to involve anybody who is involved in the management of the patients.
Of course, sir. So State Mental Health Board consists of the non-medical people, a third person psychiatrist, third person neurosurgeon, third person neurologist, third person psychologist who are not involved in the decision making who are not in the private part of the primary team, sir.
Because schizophrenia is not an indication approved by the FDA also. And all the surgeries which have been done under some research protocol or something else. I am not sure that whether schizophrenia can be, somebody might enlighten me more on this.
Sir,
but as far as FDA approval is concerned, the only psychiatric disorder which has got FDA approval is OCD. Not schizophrenia.
OCD and depression.
And depression, sir. So these are the list of cases that have been done so far.
Yeah, Dr. Himanshu, I think this is not going to end. I think the point rates are valid. Yes. Discuss it later on. Thank you. We'll call the next speaker, Dr. Soumya Ranjan. Talk on intraoperative neuromonitoring reliability.
I do understand, in spite of being so late and so tired, looking forward to the dinner, there are still topics which bring about a lot of enthusiasm and people just can't stop. I would say just hold on to your horses, board the cars, go to the dinner venue and feel free to discuss for as long as you want. Because we need to be practical enough and to make a full stop and we have to finish, otherwise we will not. Organizers have no issues, but please be mindful of time.
So, good morning. Today my topic of presentation is intraoperative neurophysiological monitoring as a reliability indicator, prognostic indicator in hand facial spasm. So, microvascular decompression, as we know, has been considered gold standard in cases of hand facial spasm, and lateral spread response is an electromyographic response as an abnormal response elicited by stimulation of one of the facial branches, and the mechanism of the same has been mentioned in the published paper of Genta and Muller as cross transmission of effective transmission of after antidromic activity of stimulation of facial nerve. So in the literature, the disappearance of LSR has been, intraoperative disappearance has been considered as an indicator of satisfactory decompression of the facial nerve, but the prognostic significance of the same is controversial. The aim was to study the intraoperative LSR response in cases of hemifacial spasm undergoing MVD and assessing the prognostic significance of the same. We have included all the cases operated between August 2022 to June 2023 in our institute and excluded the cases previously operated by botulinum toxin or any other recurrent cases. And these are the anesthetic and electrode stimulation parameters followed. This image shows the electrode placement in the orbicularis oculi and the mentalis muscle. The recording time was done at the induction of anesthesia immediately after the bone flap elevation, during the arachnoid dissection, and at the time and immediately after the Teflon patch was placed. If the LSR persisted at the end of the decompression, it was reviewed. Post-operative period observation period was immediately, that was 48 hours, early, that was 1 week, and late, that was 6 months. And total of 4 patients were operated, and these were the demographic variables. Intraoperatively, 3 patients showed complete disappearance of LSR after separation of appendic vessels from the facial nerve, as we can see from this graph. And 1 patient had showed a disappearance of LSR after the dissection was started along the facial nerve. So, as to summarize, of all the patients who had showed complete disappearance of LSR in the hemifacial spasm, in the immediate post-operative period, 2 patients had shown complete improvement, and the 2 patients have shown partial improvement. Of the patients who have shown partial improvement in the early phase, 1 of them completely improved, and in the later phase, after 6 months, 1 patient recurred. So there was no variability of outcomes as per the age, the gender, or the duration of symptom. The patient with complete disappearance of LSR only at the end of the decompression showed complete improvement with no recurrence. 1 patient was having persistent of hemifacial spasm in the immediate post-operative period. In the intra phase, he had disappearance of LSR even before the decompression was achieved. And another patient who had recurrence had associated facial nerve lipoma. So these were the 2 widely accepted theories of hemifacial spasm, and the previous literature, the recent one in 2017 by Liu et al. Shows reduction of LSR having good long-term outcome, as opposed to the previous literature of 2015 and 16 showing there is no significant long-term outcome associated with disappearance of LSR. The limitations of our study was a less sample size and duration of follow-up. And concluding, neurophysiological monitoring is an adequate guide for decompression of facial nerve, and the time of LSR also is a significant guiding tool, and we will be studying this in the extended study. And the secondary, in cases of secondary hemifacial spasm, its reliability is questionable, and we do need more sample size to generalize our interpretation. Thank you.
Thank you, Dr. Soumyaranjan. Thanks. We will go to the next paper by Dr. Bharat Jain.
Good evening all. Today we are discussing the predicting the pain relief by using the pre-treatment DTI derived metric in trigeminal neuralgia. Trigeminal neuralgia, we all know that is characterized by recurrent unilateral brief electric shock-like pain, which may be abrupt in onset and involving the 1 or more division of the trigeminal nerve, and it may be typical and atypical. It affects the patient by affecting their life and their employment as well, and it is very disabling in the older population. The incidence of trigeminal neuralgia is around 4 to 10 in 1 lakh population, and female predominance with a ratio of 1:1.8 in female. It more commonly affects the V2, V3 region and less commonly affects the V1 region. And laterality, it is more common on right side as compared to the left side, and bilaterality is very less common. And we know that pathophysiology for trigeminal neuralgia is vascular loop, which cause the inflammatory process which further lead to degeneration of the axons and demyelination, which cause the hyperexcitability of the nerve fiber. For management of trigeminal neuralgia and diagnosis for it, we have to do the clinical examination, imaging, and medical management is the first line of care, and the drug of choice for it is carbamazepine. But for refractory trigeminal neuralgia, the different treatments are available, which we can see, like microvascular decompression, stereotactic radiosurgery, RFTCs. For that, we have conducted one study, and the aim of our study is to predict the correlation between the DTI changes and the effective pain relief post-treatment. And the objective of our study is to pre-operative and post-operative DTI-derived metrics from the region of interest of trigeminal nerve on MRI will be studied, and the pain relief post-MBD and decompression and or gamma knife in the patient with trigeminal neuralgia will be compared. In our selection criteria, we have around 24 patients of trigeminal neuralgia and 7 healthy subjects, and we compare their healthy side as well as in the unhealthy side with the controls. And we actually choose the patient with typical trigeminal neuralgia and who do not have any incompatibility with MRI. Before the procedure, we have taken the detailed history, and pain score is calculated as per the Vero Neurosurgical Institute pain intensity scale, and MRI DTI was done, and patient was treated with microvascular decompression or gamma knife. As we all know, DTI is evolving non-invasive MRI technique for delineating the anatomy and pathology of the white matter tract and their relation to the surrounding tissue. In DTI, we have seen the axial diffusibility, which linked with the axonal integrity and increase if there is axonal disintegrity, and radial diffusivity, which is linked with degree of myelination, increase with degree of myelination. Fractional anisotropy is linked with the anisotropy in the box cell, which decrease with the damage to the axons. This is the demographic data of our patient. In 24 subjects, that patients, 11 were the male and 13 were the female. And the common age group is 3rd to 6th decade. For our 66% patient belong to that. And the most common region involvement in our patients is V3, followed by V2 and V3. The preoperative BNI score for our patient, most of the patient has a score of 4 and 5, and only some patients have a score of 3V. Post-operatively, the patient pain score improved, and most of the patient is come under the category of score 1, and only 2 patients come under the score of 2, and 2 patients lose the follow-up. This is the area of our interest. In this diagram, we can see the different segments of the trigeminal nerve, and these are the MRI view and the DTI image of that segments, that is cisternal segment, root entry zone, and the pontine segment. The result of our study is that in pre-treatment patient, axonal diffusibility, radial diffusibility increase at the cisternal segment in 19 and 22 patient at root entry zone on the affected side. Post-treatment, AD and RD decrease at the root entry zone, and fraction anisotropy at cisternal segment in pre-treatment affected side was decreased in 15 patient and 20 patient in root entry zone. No statistical significance was noted in AD, RD and FA at pontine segment. In conclusion, using modalities like DTI, microstructural changes in TN can be predicted. DTI value in REZ and cisternal segment correlate well with the pain relief, but the pontine segment, these things does not correlate. Thank you. These are my references.
Thank you, Dr. Bharat. We'll go to the next paper by Dr. Aiims Gupta.
Good evening, everyone. Since post-lunch, we have been hearing about these two topics, VRT and neuronavigation. So here it's a study comparing both of them. So the aim is accuracy of the VRT in localization of tumor versus the neuronavigation of the same. And the study was basically comparison between the two in accuracy in tumor localization. It was done here at Aims. It's a pilot study. It's a prospective study. Inclusion criteria was everyone aged above 12 and all those having supratentorial surfacing tumors. The methodology included image acquisition, mainly CT and MRI both, or one of them. And first in the 2D format, and then after that in the 2D format will be converted to a 3D using the volume rendering technique. So here, just showing a case, the case of a left tentorial SOL. In this, the 3D has been made, and here we can see the lesion from inside. And then craniotomy has been made, and we have marked 4 points over it, usually a superior inferior and an anterior posterior. And then the 4 points will be intersected and a midpoint will be taken. And this midpoint will be scaled from any of the anatomical landmarks, which can be a tragus pinna or else from the supraorbital rim. And then the same will be done using neuronavigation, and then both of them will be compared. So this is an intraop image in which we can see that initially with the pre-op VRT localization, we have made the craniotomy, and then using the neuronavigation we have made, and there is a difference between the two. So going on to the result, this study was the sample size was nearly 12, and in 2 patients there was no difference found between both the neuronavigation as well as the VRT. However, the lowest difference that was seen was of 2 mm, and the largest was of 1.3 centimeters. So a sample size of 12, the average difference was 4.8 mm, ranging from 2 mm till 1.3 centimeter, and none of the patients require any craniotomy revision after that. Limitations of this surgery are, it is operator dependent, it's a pilot study, the availability of a fixed anatomical landmark, the availability of a DICOM viewer, and also cranial curve negotiation, since on VRT we only draw straight lines and we cannot negotiate the curve of the calvarium. So in literature review, The many studies done, which are the latest ones are done in 2018 with a sample size of 25. In that study, nearly 9 patients had no difference. They also showed a median deviation of nearly 4 mm. The next was in 2019, which has a mean difference of 5.35 mm. And in 2011, of a sample size of 48, they had a mean difference of 5 mm. In conclusion, VRT as an option is a cheap and feasible option, and it is a close equivalent to neuronavigation to undergo craniotomy and tumor localization. Thank you.
Thank you, Dr. Ayush. We'll go to the last speaker. We'll go to the next speaker, Dr. Nihal Ahmed.
Good evening, everybody. Today I am going to present my study on the correlation analysis between the MRI and intra-op microelectrode recording in STN DBS for Parkinson's. So DBS for Parkinson's in most centers is still done with the patient awake to allow for MER recording and intraoperative clinical testing. No doubt MIR has been playing a vital part in localizing the STN and final electrode placement in the era of direct targeting. When Grenoble first used MER in 1993, the quality of MR imaging was not as good as it is today. Our technical advances today raise the question of whether MER still has added value. Problems with MER plus or minus stimulation is the increased risk of microhemorrhages due to multiple trajectories, which has been a systematic meta-analysis done by Neil and P. Rasaya from US. It shows that nonlinear increase in the risk of hemorrhage with each additional trajectory. Also, there is a patient has to be awake, off medications, and increased operative time. So, aim of this study was to find the correlation between intra-op MER and MRI in localizing the upper border of that is a rostral border of STN in patients undergoing awake DBS. Why only upper border? I'll explain later. Materials we used, we performed ambispective analysis, 30 patients of PD who underwent awake STN DBS with intra-op MER at single center from March 2022 to June 23. And we located the upper dorsal border of STN in each electrode on T2 weighted MRI thin sequences and compared it with its corresponding upper limit of intraoperatively obtained MER data after merging with the post-op CT. And each set of data was like MER and MRI were analyzed by two different researchers to eliminate reporting bias. And correlation analysis was thus performed of the two sets of data for a total of 60 electrodes. And statistically, correlation coefficient was estimated. And this is the DBS protocol what we follow at our institute. So, it was like we located the upper border of the STN in the probe's eye view. So, as you can see in this picture, we selected the uppermost section where all the borders of the STN were clearly visible and well demarcated for the MRI value. And this is the MER, increased background noise and an irregular discharge pattern with occasional bursts. This was the heat map which we obtained. And this was compared with the MRI data. Totally 30 subjects, 60 electrodes, 22 males and 8 females. So what we found is the mean distance of upper border of STN from the final target. The right side STN on MRI, the 3.82 was the distance from the final target of the electrode. Whereas in MER there was 3.38. Left STN 4 mm and MER gave 3.6 mm. And combination of all right and left together 3.9 mm. Whereas MER was given 3.5 mm. And the difference, mean difference in the MER and MRI values 0.45 mm on the right side and left 0.382 mm on the left side. And the negative value indicates that the upper border of STN identified on MRI was more rostral than the MER data in terms of distance from the final target. This is in contrast to the previous studies by Sanders Burst, which is comparative using intra-op CT. where they found that MER data was more rostral, and the correlation coefficient for right side and left side was 0.81 and 0.71, which is a strong correlation coefficient of all electrodes. Limitation of the study was this is a small number of subjects, and there might be some error in interpreting the actual MRI data. And lower border of STN could not be clearly delineated because of the inability to differentiate it from the SNR, since both are hypointense. And a better quality, maybe a 7 Tesla MRI may be able to locate the lower borders as well as other borders. So we concluded statistically that there was a strong positive correlation between MRI and MER data in locating the upper border of STN overall as well as on each side individually. Hence, we propose that good quality MRI is as accurate as MER in localizing the upper border of STN. However, large scale studies are required to further understand the clinical implications of this. Thank you.
Thank you, Dr. Nihal. Next paper is by Dr. Mehak. Dr. Mehak here. He's not here, so I think that brings us to the end of scientific session today. I think I thank my co-chairpersons for being here and thank the organizers for giving the opportunity.